Hmm.
Good evening, Chairman Sir, Nirmal Sir. Good evening.
Good evening, Jairam sir. Welcome.
Good evening, Sandil Sir.
Sir, good evening, sir.
Namaste. Good evening.
Yes, sir. Nirmal sir, good evening, sir.
Hi, good evening, Sandil.
Sir, join button, sir.
Sandil Sir, shall I share my screen and see? My screen is.
Yeah, please
Yeah.
have a check.
Yeah. Is my screen is visible, sir? Visible, audible, sir?
Yes,
Thank you, sir.
screen visible. You are audible.
Thank you very
Loud
much.
and clear as usual.
Thank you very much, sir. All your blessings will do all good things, sir. Thank you, sir. I will stop, share my screen, sir, now.
Yes, please.
Thank you, sir.
Sandil, did you call the president?
He'll be joining, sir.
Okay.
Good evening, Amadan sir. Good evening, sir.
Good evening, sir.
Good evening, sir. Good evening. Am I audible?
Audible, sir. Audible, sir.
Good evening, sir. Good evening.
Welcome, sir.
Welcome, Abudan sir.
Welcome, sir. Good
Welcome,
evening, sir.
Solomon sir. Welcome. Good evening, sir.
Good evening, sir. Good
Namaste,
evening.
sir. Welcome, sir. Tribune, sir. Good evening, sir. Namaste. Vanakkam, sir.
President sir, good evening. Welcome.
Good evening, Nirmal. How are you?
Fine, sir.
Good evening, President, sir.
Well,
Good evening, Jayanam. How are
Good evening,
you?
sir. Welcome, sir. Thank you, sir.
Good evening, President Sir. Srinivas here, Coimbatore.
Srinivas, sir. How are you?
Hi,
Hi,
Srinivas.
sir. Good
Welcome.
evening, sir. Thank you, Nirmal, sir. Thank you.
Good evening, Nirbal.
Good evening, sir.
Srinivas, good evening.
Chengutanna.
Good evening, Sridhar.
Good evening, Singaduan, sir.
Good evening, Jairam.
வணக்கம்.
President
sir, good evening,
shall
sir.
we start?
Sir, good evening, sir.
300 plus.
Good evening, Satil Kumar.
Yes, sir.
Delegate.
Sir, good evening, sir.
Good
Yes, sir.
evening. இவரு
Sir, can we
வந்துட்டாரா?
start, sir?
திரும்பியும் வந்துட்டாரா?
Yeah, one turn, sir.
Yeah,
one turn, sir.
Terrarium, Solomon, Jaya, both of them joined.
Hello, good evening, sir.
Good evening, sir.
Good evening, sir. I am Dr. Venkatachalapati.
Sir, good evening, sir.
Good evening. Welcome, sir.
Yeah.
Sir, good evening, Chairman, sir. Good evening,
Venkateshwar,
Dr.
sir.
Amudan here.
Co-sponsor, Venkateshwar, sir. Good evening, sir. Amudan, sir. Good evening, sir.
Chairman,
Yes,
sir.
sir.
வணக்கம் சார் வணக்கம் எல்லாருக்கும் வணக்கம் சார்
Yes, sir.
வணக்கம் சார் அமுதன் சார்
You are a very busy
வணக்கம்
man.
சார் by
Where are you
support and
flying
grace
today,
and
sir?
by support grace and encouragement of all seniors like you
சரியா இருக்கு சுச்சி
they have made me
காரம்லாம்
busy.
கரெக்ட் பாப்பா சாப்பிடுற மாதிரி இருக்கு உப்பு எல்லாமே பர்ஃபெக்ட்
கொஞ்சம் நான் இப்ப ரைஸ் போட்டுட்டேன் அப்ப எல்லாம் கம்மியாகும் பரவாயில்லையா
கரெக்டா இருக்கு
கொஞ்சம் கொடுத்த
Yeah,
இப்ப நம்ம
correct,
ரைஸ வேக போட்டோம்னா ஒரு உப்பு போடுவோம்ல
sir. இவரு
திரும்பி வந்துட்டாரான்னு
sir.
பாருங்க.
Sir, one turn, sir.
அப்ப ஸ்டார்ட் பண்ணலாம் பண்ணி.
Sir. One turn, sir. We'll start, sir.
திரும்பியும்
Good evening, sir. Good evening.
Sir, good evening, sir. Sir, we'll start the program, sir.
yes.
Yeah, warm greetings to all. And now I request our State Finance Secretary, Dr. Solomon Jaya, sir, to give IMA prayer and Fission prayer.
May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Physician prayer, dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift comes from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart, purpose, strength to lift at least part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine, will and worldliness, that with the simple faith of a child I rely on thee.
Thank you, sir. Now I request our AMS Wing Chairman to give his welcome address. Dr. Nirmal Patrick, sir, kindly proceed, sir. Dr. Nirmal, sir.
He was there?
Sir, and Dr. Nirmal, sir, he was there, sir, just now. Just a minute, sir, I'll call him.
Ah,
Hold on.
இப்ப இருந்தாருப்பா.
Yes, sir.
என்னோட பேசினாரு.
Sir, and meanwhile, we have a very good registrations for this CME also, sir. So we have close to 1,450 registrations, sir. So I think we'll be having our zonal next month, sir. Sir, kindly give you a welcome address, sir. We're waiting, sir. Yes, sir. Sir, meanwhile, just give my short report about our proceedings, sir. So this month we are having our CME on World Sleep Day. So and also we have our sleep medicine course being inaugurated today. And next month will be our zonal conference of AMS wing. So this will be held in Tambaram. This will be a hybrid meeting. I request all our members to kindly participate in large numbers. Nirmal sir, request you to give your welcome address. Juliet sir, co-host பண்ணிருங்க. Juliet, Nirmal sir, co-host பண்ணிருங்க. Jayaraman sir, I request you to yes. Sir,
Looks
can
like
we
he has
proceed,
some
sir? Yes, sir.
issues. So
Yes,
he
sir.
just pushing
So
getting
yes,
join
sir.
us.
So we welcome all our state leaders and speakers of the day and all our participants for this wonderful CME today. And now I request our state president, Dr. Sridhar sir, to inaugurate the CME and as well as the sleep medicine course, which is a fellowship course in AMS wing. So kindly proceed, sir.
Thank you. Good evening, all. The most respected immediate past president, Dr. Sengutu Anna, President-elect, Dr. Ravi Kumar, AMS National Vice Chairman, Dr. Amudan sir, then the AMS chapter office bearers of the state, Dr. Nirmal Frederick, Dr. Sendil Kumar. It's a great leap ahead for AMS these days, and I can see a lot of good things happening in AMS nowadays. Those days, when I was a younger person trying to get into state thoughts, AMS was seen as one small consolation prize for somebody who wanted to become a state office bearer. நீ வேணா ஏஎம்எஸ் செக்ரட்டரி எடுத்துக்கோ சேர்மன் எடுத்துக்கோ something like that. People used to give it, offer it as a top சமாதானம். But today it has woken up as a giant, sleeping giant, and this sleeping giant has become a woken up lion and roaring strong and sound, and they are going to now conduct a CME on sleep medicine. Actually, I think it is going to be an entirely separate course to be offered with the faculty like Dr. Jayal Haman. I think we are going miles in IMA Tamil Nadu as far as our academic wings are concerned. AMS, CGP, paramedical, all are doing great work and making us proud. Like the other day, Dr. Jailal was mentioning, Sridhar and Tirame are very lucky to lead a association with vibrant wings and schemes. I think I was a little flattered at that moment when he said that. And the credit goes to the young and vibrant office bearers of the wings and schemes. who have really changed the landscape of these schemes and wings. And I'm very confident AMS will go miles further before I step down. I'm very sure that AMS will be seeing more such wonderful programs under its belt. So I wish this team all the best. I appreciate Dr. Jayaraman for taking this initiative on a very little known topic. I think only people beyond 60s they talk about this sleep apnea, BFAB, CFAB, some oxygen, extra oxygen in the night, and other things. But I wonder how many of the younger generation, maybe it has come as a textbook course nowadays. But in those days, when we were young students, sleep apnea was a foreign word. We have not heard of it. It was not discussed. We didn't have it in the academics. So now it has been recognized as a real big problem for the younger.
சொன்னீங்க
ஜூலியட் கொஞ்சம் எல்லாத்தையும் மியூட் பண்ணிருங்க.
So what was a foreign like word 2 decades back now has become a real big topic of discussion. I congratulate AMS and Dr. Jayaraman for having come up with the course. And with the course, a great success. And maybe they will come up with more such courses in future. I wish all the participants a great day of education and enlightenment. And I congratulate the office bearers of the AMS, both the national and all the very best. Thank you, Sandil. Over.
Thank you, sir. Now I request our State Secretary, Dr. Derivi Mohan, sir, to give his words of felicitation.
Respected State President Sridhar sir, immediate past President Dr. Sengutuvan sir, President-elect Tyagarajan sir, Ravikumar sir, my Finance Secretary Dr. Solomon, the Dr. Venkatachalapathy, the AMS National Chairman, Amudan sir, Sriram sir, Nirmal Frederick sir, Sendil and Ibrahim. First of all, it is my pleasure to be a part of the CME on World Sleep Day and the inauguration of the fellowship courses in sleep medicine organized by the AMS wing of IMA Tamil Nadu. I congratulate the AMS wing for organizing the team, organizing the CME, and they have brought together eminent experts from pulmonology, ENT, neurology, and psychiatry for this academic program. That is the main success of this program. And with the help, with the guidance of Dr. Jayaraman, they're going to do a wonderful job. The launch of this fellowship in sleep medicine is a commendable step that will strengthen training and awareness in this emerging specialty. I don't want to waste much of time. I wish the CME a great success and all the participants are given invaluable sites. Thank you, Dr. Sendil. Thank you.
Thank you, sir.
Sendil, Dr. Nirmal is online.
Yeah.
Yes, sir. Nirmal, sir. Yes, sir. Yes, sir. So now I request our immediate past State President, Dr. Sengutuvan, sir, to give his felicitations.
Thank you, Senthil. Respected President Sridhar, President-elect Ravikumar, NRTR Tyagarajan, Honorary Secretary Dr. Derivi Mohan, Finance Secretary Dr. Solomon Jaya, AMS Chairman Dr. Frederick, Secretary Dr. Sendil Kumar, Ibrahim, and Academic Fellowship Course Coordinator Dr. Jayaraman and his colleagues. Good evening to everybody. This sleep medicine is the important one and it should be known to all what is happening. It is a multi-speciality. It not only involves the pulmonologists, it's also ENT people and other people also involving. So this course will be highly useful for all the medical specialties people, that the team will be a greater one, and wishing the function very success. Best wishes to the AMS team. Thank you.
Thank you, sir.
Over to Sendil.
Yes, sir. Thank you, sir. Now I request our President-elect 2026, Dr. A.K. Ravikumar, sir, to give his felicitations.
Thank you, Dr. Sendil. I am traveling. You may be having some disturbance in my voice. Anyway, it's my respects to the President. I meet the past President, Chairman, and National Office Bearers, and the wing office bearers. I'm very proud that the IMA Tamil Nadu is doing wonders. And AMS wing, especially the AMS wing, continuously you have been IMA AMS wing of Tamil Nadu has been backing up the best AMS wing chapter from the national level for the last consecutively 3-4 terms. So best wishes to you all. And this sleep medicine program is really a wonderful program. Actually, as Dr. Sridhar was mentioning, earlier we were not very much into these sleep medicine at all. Because of so many changes in the lifestyle, childhood obesity, and so many other stress involved, sleep has become a very important one. So நீங்க வந்து தூங்காமையும் இருக்க முடியாது. You cannot be without sleep. If you sleep more also, it is a problem. If you sleep in bits also, then it is also a problem. So you should have a continuous sleep of about at least 7 to 8 hours. Unless that is there, the human body gets totally disturbed. I am very happy that the galaxy of people from neurology, psychiatry, ENT, and pulmonology has been brought in to take up this course. I wish this course a very good success. And today's program will definitely be a very useful program. And my suggestion to state office is now that we have started the YouTube channel for public, we can have a session on sleep, importance of sleep in the YouTube channel also. So thanks for giving me this opportunity. Best wishes. Thank you.
Yes, sir. Thank you, sir. Now I request our President-elect 2027, Dr. N.R.T. Tyagarajan, sir, to give his felicitations.
Yeah, good evening. Thanks, Sandal. Respected President, Secretary, Treasurer, and incoming President, immediate past President, National Office Bearers, and to the entire AMS team, good evening, and to all the participants. Well, almost every week we are having some very good academic activities since the beginning of this year, either from the academic committee or from the AMS or from the CGP. All the academic teams are doing amazingly well with the very good attendance in almost everything. And every topic that they pick up is so carefully selected. And right now, sleep medicine, which is an emerging specialty and subspecialty, and headed by Jayaraman sir, our incoming Vice President, I'm sure it'll be very interesting. So looking forward to the topics, to the inputs from the entire team today. And thanks for this opportunity, and congrats to the AMS team for this. Thank you.
Thank you, sir. Now I
Sandil,
request. Yes, sir. Yes, sir.
I forgot to mention the presence of President-elect
Chairman,
2027, Nadia Tyagarajan. I thought he was not there. So nice to see you with your shining shaven face.
Yes, sir. Thank you, sir. Yes, sir. Yes, sir. Thank you, sir. So now I request our National Chairman, IMA AMS Headquarters, Dr. M. Venkatachalapati, sir, to give his words of felicitations.
Yeah. Good evening, all. At the outset, I would like to thank the organizers of this webinar for giving me this opportunity, and particularly Dr. Nirmal Frederick, who was after me long back, somewhere last week or so. He was very particular about me participating in this webinar. So this is a very, very important topic, as many of my predecessors have already told. Sleep is a very important part of human cycle, biological cycle rather. So sleep is the time when the body does lot of repair work. So clearing the metabolites or healing other bodies that have been working for the full day. So that's a very important thing, but unfortunately, it is not openly discussed. So in a very vast platforms like this, and this is a wonderful thing that the Tamil Nadu state branch of for AMS have brought out this. So at the outset, I would like to thank this AMS Tamil Nadu branch, and particularly all the office bearers who are there in this platform Actually, I've logged in through my mobile. I'm not able to see overall there, but anyhow, I'll try to recollect. Dr. Sridhar, I think, is the president of Tamil Nadu branch, and Ravi Kumar, who is a very close friend of mine, is the president-elect of Tamil Nadu 26, and also Dr. Tyagarajan is the president-elect of 2027. And I can see Dr. Amutan, who is my colleague at IMAMS National Headquarters, as a vice chairman of our national body. And also, I think Dr. Nirmal Frederick is there. So I wish each and everyone take this opportunity to wish them, and also all the participants. And I once again wish this program a grand success. And also, I think you can count on me for anything that can be done from the national body of IMAMS. Please feel free and try to contact me or Dr. Amutan if you want anything from IMAMS from the headquarters. I am there always to serve you. Thank you so much. Thank you so much for giving me this opportunity. Thank you so much.
Sure, sir. We'll be calling you, sir. Thank you.
I got a small one more program to attend. Maybe I leave slightly prematurely. Thank you so much once again. Thank you.
Yes, sir. Thank you, sir. Thank you, sir. Yes. Sir, now I request Dr. S. Jayaraman, sir, who is the course coordinator for sleep medicine course, as well as he is a senior consultant pulmonologist in MGM
Sorry
Healthcare,
to
Chennai.
disturb you.
Yeah, yes,
Please,
sir.
please give a chance to Nirmal.
Yes.
He's online now.
Yes, sir. Yes.
Thank you, President. Sorry, I couldn't give the proper welcome address because of a technical glitch. I've rejoined. So once again, I welcome all the dignitaries for this program, even though it is a bit late. Thank you, President Dr. Sridhar, for guiding us, not only for this program, but also for all the future programs we have designed. So on behalf of the AMS team, welcome all the dignitaries, the state, national chairman, Dr. Venkatachalapati, Dr. Amudan, and Dr. Sairam, and also the course faculty led by Dr. Jairam, Dr. Saktish, and Dr. Ramya Sampath, and Dr. Srivardhan. So who will be taking us through this important topic, which is not only very important, but now is gaining rapid momentum across the various specialties. And it is appropriate that Academy of Medical Specialties has taken up this initiative under the guidance of Dr. Jairam, because not only what was considered as only pulmonologist or ENT's fort, now it is affecting each and every specialty: cardiology, endocrinology, ophthalmology, psychiatry, general medicine, and every specialty. So in fact, it comprises the whole wellness spectrum, and it is important that our members learn the nuances of sleep medicine. So I'm happy to see the wonderful program, the structured program for this course. I'm sure it will be beneficial to all our members. So the best bridge between despair and hope is good night's sleep. So the moment we lose this sleep, then it becomes difficult not only for the common public, but also the doctors. So welcome to Sleepmedima. I also request all of you to join us for the AMS conference North Zone planned in Tambram on August 19th, and also subsequent programs planned by the Academy of Medical Specialties. So next month, we'll also be introducing a new course on diabetic retinopathy, and as well as cornea retrieval program. Thanks to the guidance of our president, will be collaborating with the hospital to bring this cornea retrieval program and train our members through Academy of Medical Specialties. So with this information, I welcome one and all for this program. And over to you, Sendil.
Yeah, thank you so much, sir. So now we introduce our course coordinator, Dr. S. Jayaraman, sir, who is a senior consultant pulmonologist, MGM Healthcare, Chennai. So over to you, sir. Kindly proceed with your overview of sleep disorders. Thank you, sir.
Thank you, sir. Is my slide visible, sir? Voice is audible?
Yes,
okay,
Yes,
thank you.
yes.
Very good evening. First of all, I thank you, all the IMA leaders, for this wonderful opportunity in this World Sleep Day commemorative talk. So first of all, I thank all my delegates and members, those who are joined in this prestigious program. Every year we do the annual program of the for the commemoration of World Sleep Day. So thanks for the wonderful opportunity. All the leaders, thank you very much. So today I will be discussing about the sleep disorders overview, followed by we have 4 eminent faculties. That is a pulmonologist perspective of sleep disorders, and the neurologist perspective of sleep disorders, and the ENT perspective, surgical perspective of sleep disorders, and the psychiatric perspective of sleep disorders. Sleep is an important, vital, metabolic function of the body. If you take the good health, you want a good health, the pillars of health are diet, exercise, and sleep. Among all the 3, sleep is a paramount important. So I'll so the slides, how the sleep is important, what are the common sleep disorders. But in general, sleep and sleep disorders are very much under-recognized, under-diagnosed, under-treated conditions. So we have a lot of sleep disorders. So one by one, I'll explain in detail about that with the practical tips. So every year we do the World Sleep Day in the month of March. So we have wonderful faculties today. So thank you, AIMS team under the chairmanship of Professor Nirmal Frederick sir and Sindhil sir for giving me this opportunity to moderate this World Sleep Day CME program. As well as the giving the chance, I thank the IMA leaders for giving me the chance to coordinate the Sleepmedima course in MGM Healthcare. So now we'll be starting the 3rd batch of Sleepmed IMA. It's a fellowship certificate course in sleep medicine from March 15th onwards. I request everyone, this is a multi-departmental Sleepmed IMA course, fellowship course in sleep medicine. This is for 6 months course. I'll explain in detail about that. I thank you all my faculties today to join as World Sleep Day commemorative lecture talk. I thank Dr. Krishnaveni ma'am for the wonderful support. Dr. Saktesh, surgical perspective OSA, and Dr. Srivardhan, neurologist from MGM, and Dr. Ramya Sambat ma'am, psychiatrist from MGM Healthcare. I thank you all the faculties in this program. So Sleepmed IMA is a 6 months online, offline course. I thank you IMA and the AMS team for this wonderful knowledge disseminations in this platform. The Sleepmed IMA, the course highlights are, so we'll teach all kinds of sleep disorders and diagnostic testing and treatment modalities and case-based multidisciplinary discussions and dental sleep medicine and pediatric sleep disorders, etc. So we do every Sunday. So minimum 3 classes per month. So first Sunday online, second Sunday offline, third Sunday online. Likewise, we do the courses Sunday 10 a.m. to 1 p.m. with a kind of a sleep masterclass and sleep workshop. The workshop usually, which will be held at the MGM Healthcare Auditorium. So we'll do a lot of multi-departmental faculties will join and explain all about the diagnostic and therapeutic perspective. This course fee will be the 35,400 for 6 months course with GST. I request everyone kindly go through our Tima newsletter. All the details are available. Please feel free to call me or our AMS team. So we'll guide them to disseminate the knowledge about the sleep medicine and sleep surgery. So this is a small video. Kindly listen. It's a very important biohack. Which is the most important biohack? I'll put that.
Biohack. Our body to live up to that age of 100, to not oxidize, to not age, and to have that longevity. What is your secret?
The biggest biohack that you can implement is sleep.
Sleep is your biohacking tool?
Yes.
Not a supplement?
No.
Not the red light therapy?
No.
Not exercise?
Exercises.
But sleep is number 1?
Sleep is number 1. So I have this framework called GENES.
Yeah.
G stands for gut health. E stands for exercise. N stands for nutrition.
Yeah.
E again stands for emotional health, and S stands for sleep. If you are not sleeping, it doesn't matter how much you exercise, how much good food you eat, you will die early. You will die early and you will die with a lot of diseases. Your single biggest weapon is sleep.
So sleep is such a paramount, important, vital metabolic function. This is not a luxurious thing. Nowadays, a lot of changes happening in the world because of the this globalization. Lot of MNCs and night shift workers and the late night sleep and the lot of issues, multifactorial. We are seeing lot of sleep disorders nowadays. So this is the gentleman, we call it as the father of sleep medicine, William Charles Demand. He is founder of the American Academy of Sleep Medicine, and he is the inventor of the polysomnography and the REM stage of sleep, etc. So William Charles Demant. So broadly categorized into sleep department. So there are two major departments. One is the sleep medicine department and the sleep surgery department. Already mentioned, this is a multi-departmental thing. So multidisciplinary approach. Like oncology team, if you take a tumor board, so medical oncology, surgical oncology, radiation oncology, likewise here. So we have the sleep medicine team, sleep board, which consists of the pulmonology, ENT, psychiatry, neurology, bariatric, etc. In that sleep medicine, so under this, there are 5 specialists, mainly the pulmonologist, psychiatrist. What is the psychiatrist's role here? If you take the insomnia, among all the sleep disorders, insomnia is the paramount important #1 disorders among the sleep disorders. So psychiatrist's role is very, very important. Our father of sleep medicine, William Charles Demant, is the psychiatrist. Neurologist, very, very important. Sleep stages. Based on the sleep stages, we can do all kinds of diagnosis of various sleep disorders. So endocrinologist, what is the role of endocrinologist? Nowadays, we are seeing a lot of global obesity epidemic. Yesterday, there was a day called World Obesity Day. A lot of talk, bariatric medicine, bariatric surgery. So 50% of the Indians are obese. Nowadays, lot of problem. Obesity itself is a disease. Obesity disease, because of the obesity head to foot, there are a lot of systemic inflammations. So one of the diseases is the OSA. So, and the pediatric age group also, we see a lot of pediatric obstructive sleep apnea and a lot of syndromic children. They have a lot of sleep disorders. Coming to the sleep surgery department, sleep surgery mainly consists of the ENT and head and neck surgeon. The role is very, very important in pediatric OSA. 80% of the pediatric obstructive sleep apnea, the etiology behind is the adenotonsillar hypertrophy, which is the culprit behind the pediatric OSA. The treatment of choice is adenotonsillectomy by the ENT surgeon. 80% is a cure completely. 20% of the syndromic children may require the sleep study and the PAP therapy, weight reduction, hormone corrections, etc., etc. And coming to the oral and maxillofacial surgeon, if you take the craniofacial morphology, lot of structures, abnormalities present from the birth. Since birth, we see a lot of the abnormalities. So we have to catch them young in the pediatric age group, and we do a lot of corrective procedures and the myofunctional therapy and a lot of treatment modalities with the pediatric dentist, periodontist, and maxillofacial surgeon, orthodontist, etc. Role of bariatric surgeon, any BMI more than 30 or 35 or 40, we call it as the morbid obesity. The role of bariatric surgeon is very important. So nowadays we have a bariatric department. There are 2 arms. One is the bariatric medicine, other one is bariatric surgery. Bariatric medicine, nowadays a lot of drugs are available like semaglutide and tirzepatide. So we have to give the weekly injections for 6 months or 1 year. There is a very good drastic weight reduction. So head-to-head trial, the bariatric surgery or bariatric medicine. So we'll discuss in detail about with other speakers. This is the classification of sleep disorders based on the international classification ICSD-3. So first common disorders we come across in our practice is the insomnia, lack of sleep or inability to get to sleep. We have a speaker, Dr. Ramya Sambat ma'am, will be delivering the talk about the insomnia, primary, secondary, etc. Next common sleep disorder is the sleep-related breathing disorder. So this is a spectrum of disease starting from snoring, upper airway resistance syndrome, and sleep apnea hypopnea syndrome, and obesity hypoventilation syndrome or quick-weekend syndrome. A lot of sleep disorders. Among all these sleep disorders, the OSA, obstructive sleep apnea, is a very malignant disorder. If you don't treat this OSA, may lead to a lot of complications from head to foot. One of the worst complications of the OSA is the sudden death during sleep because of the choking, lack of oxygen, hypoxic, arrhythmias, and arrest. This is one of the important thing. And we have central disorders of hypersomnolence, circadian rhythm sleep-wake disorders, parasomnias, all comes under the neurologist perspective. Example, narcolepsy, idiopathic hypersomnia, and the periodic leg movement disease, etc., etc. We have a neurologist now. He will be talking about the parasomnias and restless leg syndrome, etc. And the sleep movement disorders, other sleep disorders. This is the classification of the sleep disorders. Snoring. This is a layman terminology. You ask any layman, snoring in sleep, majority, 90%, you ask any layman, mama nalla kotta podu thunguraru, nalla thookam, good sleep. They are thinking in terms of kotta vanda nalla thookam apdi nenichittu irukanga. That is a very, very wrong way. The physician knows that snoring is a symptom of upper airway obstruction. Snoring is not a normal sound. This is an abnormal respiratory sound during sleep because of the turbulence of airflow in a narrowed airway. Vibrations from upper airway wall producing the sound called the abnormal sound called snoring. There are two kinds of snoring, physiological and pathological. Physiological or simple snoring, it will be there for 2 days, 3 days, 5 days maximum, that's it. Because of the cold, allergy, infections, and deflected nasal septum may cause simple snoring. But sleep apnea snoring is a habitual snoring. Any person is having daily snoring during sleep, we have to rule out obstructive sleep apnea. So what is habitual snoring? Breathing passage, mainly in the retropalatal and retrolingual areas, narrows while sleeping and produce partial or complete blockage of the upper airway. So snoring is an important spectrum to start with the sleep disorder breathing. Then common disease among the sleep is the obstructive sleep apnea. Very, very important disease. What is obstructive sleep apnea? My next speaker, Dr. Krishnaveni, will explain detail about that. I'm not going to detail about OSA and all. So this is upper airway block. Common OAD, obstructive airway disease, we see in the respiratory practice. The lower OAD is the asthma and COPD. Upper airway, obstructive airway disease is the sleep apnea. It's a very, very common disease. This OSA is considered as a mother of modern epidemic disease in the world. So we're all thinking in terms of diabetes. So India is the diabetic capital. If we take the overall the sleep apnea burden in India and the global, it's a high sleep apnea burden country. India is a high sleep apnea burden country. So this is the prevalence of Indian and global scenario, very, very high incidence. Coming to the symptomatology, so snoring is a very important night symptom, increased frequency of urination, irregular breathing during sleep, and partners witnessed stoppage of breathing, night sweat, increased cough. One of the symptoms of refractory cough, reactive cough due to the obstructive sleep apnea. Sexual dysfunction which leads to divorce and the marital disharmony, so unsatisfied activities which leads to a lot of separation. Palpitation, one of the symptoms of the right symptom of the OSA. Excessive daytime sleepiness. Coming to the daytime, excessive daytime sleepiness. This is a hallmark symptom in a male predominant. Feeling tired, lack of energy, fatigue. This is a female predominant symptom. Early morning headache, again, female patients, very, complain of headache and other thing. Diabetes, we are all, diabetes capital. India is diabetic capital. Any diabetic patient, we have to rule out OSA. So we have to do the screening test and find out whether OSA is there or not. Concentration, memory problem. Children, we are seeing a lot of memory problems, not able to concentrate, work in adult also. High BP, there is a strong relationship between the OSA and the hypertension. Depression, anxiety, irritability because of hypoxic encephalopathy, which leads to a lot of negative thoughts. Learning difficulties in children, these are the common symptomatology. So without snoring also, they may present no sleep apnea. There are 2-3 categories based on the symptom. One is the hypersomnia, excessive daytime sleepiness. Other one is the insomnia, lack of sleep. In between the group called asymptomatic or minimally symptomatic group. So we have to ask the history thoroughly to rule out what kind of thing. So based on the phenotype is nothing but is a clinical presentation. Based on the clinical presentation, we have the 4-5 basic phenotype. One is risk factors, obesity, craniofacial restriction, neural and mentality control. Clinical expression, sleepiness group, insomnia group, or asymptomatic group. Physiology features mainly the sleep stage dependency. Body position, there is a position associated with OSA. Hypoxic burden is an important terminology which may lead to a lot of problems. Heart attack, stroke, cancer. Cancer also one of the important risk factors. And the heart rate response, the various etiology behind. Based on the morbidity factors, hypertension, cardiometabolic dysregulation, neurodegeneration which leads to dementia and Alzheimer's disease. Cancer, one of the etiology behind the cancer is multifactorial. One of the causes is the hypoxic burden and OSA. These are the common clinical conditions we come across in our practice left and right. Systemic hypertension, obesity, myocardial infarction, CV or stroke, pulmonary hypertension, type 2 diabetes mellitus, nocturnal cardiac arrhythmias which leads to sudden death. Driver involved in a sleep-related automobile crash. One of the rotary accident causes is the drivers not able to get a proper sleep because of the OSA. Pre-operative anesthesia evaluation is very important for anesthetist and surgeon. So any case, any obese or any snoring individual, hypothyroid individual, we have to evaluate before the surgery. Uncontrolled asthma, one of the important comorbid conditions of asthma. Cancer, there is a strong link between the hypoxic burden and the cancer. Questionnaire, we have a lot of questionnaire. I'm not going to detail about that. Krishnaveni will talk about that. The common questionnaire we practice in our OPD, in the reception area. We give the questionnaires to the patient and patient attenders. Then we calculate how much severity of the clinical evidence of OSA. The snoring, S stands for snoring, and T for tired, and O for observed any choking sensation or blood pressure. BANG means BMI, age, neck circumference. So based on this, we calculate the score. High score or more prediction of the OSA. And other important daytime sleepiness scale assessed by the ESS F4 sleepiness scale. This is also very, very important. Based on this, we calculate how much severity of the OSA, because excessive daytime sleepiness is one of the hallmark symptoms of the OSA. How to diagnose sleep disorders? Sleep study is the gold standard. Level 1 is the polysomnography. This is the gold standard test. Level 1 or in lab or in hospital study with no trained technicians, no supervised technicians throughout monitoring. They will monitor throughout the night. This is the level 1 sleep test. Other sleep tests are level 2, home sleep apnea testing. Level 3 is cardiorespiratory channel testing or polygraphy, not polysomnography, polygraphy. Type 4 is screening modalities and lot of wearable devices. So Dr. Sleepmedima will explain detail about that briefly. So once you diagnose the problem of the sleep disorders, mainly the obstructive sleep apnea, the treatment is multidisciplinary. Already mentioned sleep board. We have to have the multidisciplinary team which involves the pulmonologist, ENT surgeon, bariatric surgeon, endocrinologist, and maxillofacial surgeon, dentistry, etc. We have to combinely, because OSA mostly in adult population is a long-term, lifelong disease. We have to control effectively or treat effectively to prevent unnecessary complications. So conservative measures, weight loss, position therapy in the case of mild to moderate OSA, alcohol cessation, tobacco cessation, and nasal decongestion. This is all the start with the basic important treatment. Weight loss, we have a lot of obesity bariatric treatment available nowadays with the bariatric department. In our center, we have the Nalam clinic, which take care of all kinds of obesity problem. ENT consultation is very, very important. Historically, before 1981, the treatment of choice for OSA is the tracheostomy. After the invention of CPAP, continuous positive airway therapy, the treatment revolutionized to the tracheostomy to the PAP therapy is a gold standard first-line therapy. So ideally, ENT consultation should be offered to all the patients of OSA, whether they may tolerate the PAP therapy, whether nasal passages is open or not, any different nasal septum, or any polyp, or any dominant hypertrophy. We have to assess thoroughly by the ENT surgeon. They put the light and see by nasopharyngoscopy to see whether the patient is able to tolerate the PAP therapy or not. Very, very important ENT opinion. So PAP therapy, positive airway pressure therapy is a gold standard treatment for obstructive sleep apnea. What is CPAP? This is the continuous positive airway pressure. The first described by Professor Dr. Colin Sullivan et al. He published a paper in the Lancet in 1981 as a treatment of OSA. It works as an air splint to maintain upper airway patency during sleep. It's open up the airway. So most effective non-invasive therapy. This is Dr. Professor Colin Sullivan, is the inventor of CPAP in 1980, and various kinds of PAP therapies are available: CPAP, automatic PAP, and bilevel PAP. This is an interface, very, very important. Nasal, this is a full face mask which covers nose and mouth. This is a nasal mask, and this is a nasal pillow insert. And this picture shows this is the a chin strap. Those who are having the mouth breathing during sleep, we have to wear these kind of things. Apart from, additionally, we have to wear the mask to prevent upper airway block. This is nasal insert and nasal mask, various kinds of interfaces nowadays available as a very, very patient-friendly, various types of very handy PAP machines are available. Coming to the non-surgical treatment, oral appliances is a second-line treatment for the obstructive sleep apnea. We have a mandibular advancement device, tongue retaining devices. So we get an opinion from the dentistry, mainly the maxillofacial and the pediatric dentist for these kind of treatment modalities. Adjustable mandibular reposition devices. Again, our maxillofacial surgeon will prescribe based on the patient's craniofacial abnormality. They will prescribe these. Coming to the surgery in obstructive sleep apnea or sleep disorders, adenotonsillectomy is a gold standard treatment for pediatric OSA. And in a mild to moderate OSA in a young or middle-aged individuals with the upper airway surgery, the ENT surgery plays a major role in curing the problem completely. So in adult, 25 to 30% we can cure. And we have a maxillomandibular advancement osteotomy for retro and macrogranthia. So we get the opinion from the maxillofacial surgeon. Bariatric surgery for morbidly obese BMI. Those who are BMI is more than 40, we refer the patients for bariatric surgical evaluation. Before that, endocrine evaluation is the paramount important. So investigations for surgical patient, mostly a dynamic or sleep MRI, to find out the level of obstruction, whether it's retropalatal or retroglossal. DICE is important procedures to see the where exact level of obstruction, where to operate, whether circumferential collapse or anteroposterior lateral collapse. They put the endoscopy and the drug induce. This Dr. Saktis will explain in detail about that. Facial capillometry is an important investigation to find out craniofacial abnormalities, to find out whether retrognathia or micrognathia. And hormonal evaluation, mainly the hypothyroid, is one of the common association. And the CTPNS, one of the comorbid conditions we come across in our practice. So this is a common investigation of surgical patient. This is the 80-year-old pediatric OSA patients presented with mouth breathing, snoring, and daytime tiredness. In the classroom, is sleeping always. So reason behind OSA in pediatric age group is the adenotonsil hypertrophy. The treatment of choice is adenotonsillectomy. In 80% of cases of pediatric OSA, this is a curative surgery. Maxillomandibular advancement osteotomy by the maxillofacial surgeons. They will do the this kind of procedures. This is a complete cure for this kind of patients, mild to moderate OSA. And bariatric surgery BMI is more than 37.5 or 40 with this thing. So we refer the patient for the bariatric surgery. So the take-home messages from my presentation: sleep disorders are very, very common, but under-recognized, under-diagnosed, under-treated condition. You all had a metabolic syndrome or syndrome X. There are 4 components. One is the diabetes, hypertension, dyslipidemia, and obesity, plus obstructive sleep apnea. We call it a syndrome Z. The diagnosis and management of OSA is imperative to avoid further complications in the patients. Treatment is multidisciplinary. PAP therapy is the first-line treatment. And non-PAP therapy, mainly the oral devices, oral appliances, the second-line treatment. Third line, mainly the surgery. I'm talking about adult patients. ENT head and neck surgery, maxillomandibular advancement osteotomy procedures, bariatric surgery plays a major role. We have to choose a patient effectively. So each and every person is different. We have to have the individualized medicine or personalized medicine. Nowadays, we are all practicing in an era of precision medicine. One size does not fit for all. We have to choose the patient meticulously based on the phenoendotype. We have to choose the surgical treatment options effectively. Nowadays, we have artificial intelligence in precision sleep medicine, both diagnosis and treatment. In future, there are a lot of wearable devices, wireless device. We can monitor the sleep pattern. Based on this, we can diagnose the sleep disorders very clearly. So with that, thank you very much. This is our sleep clinic launch in 2023 by Professor Dr. Padma Shri Narayan sir. This is a World Sleep Day 2023 walkathon program. And we have a 24 World Sleep Day program. This is our mentor of sleep icon, Dr. Shivani Swami from Jaipur. He is our Secretary of Southeast Asian Academy of Sleep Medicine. And this is Sleep Lab inauguration in 2024. And this is again, we started a Southeast Asian Academy of Sleep Medicine Tamil Nadu chapter. We inaugurated by our Dr. Kasi, former Vice President of the IMA TNSP North Zone, and all the leaders here. And I welcome everyone to take part in our Sleep Summit program next Sunday. That is 15th March in Chennai, Hotel GRT, one-day conference. We have various speakers national level. I welcome everyone to take part. And from the IMA AMS side of Chennai, we welcome, and all the IMA branches, we are planning a mega level walkathon, awareness walkathon for the general public and doctors at Tower Park, Anna Nagar. Please note down the date and welcome to join. This is our international conference of Southeast Asian Academy of Sleep Medicine 2026, which will be held at Ahmedabad on 21st to 23rd August. I welcome everyone. Kindly save the date. Welcome to join this mega international conferences associated with the Australasian Sleep Association. So with that, thank you very much for the wonderful opportunity. So any questions, I'll be happy to take now. If there are any questions, you can put up in the chat box or unmute your mic, you can ask. I will put the question. Otherwise, we'll move on to the next talk from my colleague, pulmonologist, Dr. Krishnaveni. He is a consultant pulmonologist from allergist and sleep medicine expert from the Medway Institute of Pulmonology in Chennai. Shall we go to the second presentation? Okay. May I invite Dr. R. Krishnaveni, so MD and fellowship in sleep medicine. He is a senior consultant, allergist and sleep medicine expert from the Medway Institute of Pulmonology, Chennai. for the talk on the sleep disorder breathing pulmonologist perspective. Over to Dr. Krishnaveni.
Hello, sir. Is my screen visible? My voice is audible.
Audible, visible, yeah.
Yeah, 1 second. Let me share the presentation. Just a minute. I'm just sharing.
I request all the delegates, if you have any questions, please put them in the chat box. We'll address appropriately regarding any kinds of sleep and sleep disorders.
Dr. Jayaraman?
Good evening, sir.
On behalf of all the IMA members, only one simple question repeatedly asked by the patient attender.
Yes, sir.
Any specific phenotype of OSA in India? Exclusive for India, that is special phenotype or general with other countries?
Yes, sir. So Indian populations are high sleep apnea burden country, India, because of the craniofacial abnormality. So a lot of patients from the since childhood, they develop a lot of the craniofacial abnormalities like retrognathia, micrognathia, and high arch palate. There are a lot of anatomical factors which contribute to the Indian population later on, full-fledged OSA with a lot of comorbid conditions, hypertension and all. So the craniofacial one is one of the important factor behind. And nowadays, a lot of global burden of obesity, also one of the important phenotype. So these two are very important things. One is the craniofacial abnormality since birth. Other one is the once age advances because of the sedentary lifestyle. Because of obesity, a lot of sleep apnea we are facing. Yes, these two are very important. One is the craniofacial, other one is the obesity type of phenotype. It's very common in India. Yes, so when you compare to Western world, India is a high sleep apnea burden country because of these two etiology. Yes, sir.
So one more common question asked by the attenders. Immediately they don't accept for the surgical or appliances. So they always ask one question. Should you give a trial of medical treatment before surgical? What is your opinion?
Yes, sir. See, always the CPAP is the first line therapy, is a gold standard treatment, whether mild, moderate, severe and all. If the patient is not able to wear the mask properly or the poor adherence, patient wants alternative treatment, non-PAP therapy, then we counsel the patient such a way that so meticulously examine and thoroughly pinpoint the phenotype, whether surgical candidate or oral appliances to be applied. So this way we proceed to fix the treatment perspective with the consultation with our colleague ENT and maxillofacial surgeon, sir.
Well done, sir. Keep it up. Thank you. God bless you.
So one
Thank you,
question,
Thank you very much.
Patients want to know whether using the PAP apparatus for snorers will interfere with their quality of sleep, whether it will prevent them from turning around from side to side in the bed while asleep, or is it painful in any way?
Madam, nowadays we have a very patient-friendly nasal pillow, small nasal pillow and nasal mask with a very soft gel quality type of available now. There is no pain, no discomfort. The patient can wear with very nicely. They can tolerate very well. Initial 3-4 days, maximum 1 week, they feel slight difficulty. They use 1 week later, they feel tremendous improvement. Daytime active, alert, energetic. The bed partner feels there is no snoring. They have very good sound sleep. Sound sleep in the sense, so without any sound, without any snoring, they have a very peaceful, good sleep. The morning wake up, they feel refreshed, active, energetic. So these are the advantages. Nowadays, we have a very patient-friendly mask and tubings and machines. The lot of software updation with the AI involvement. We have a wonderful PAP treatment nowadays available, madam. When you compare to 10 years before, nowadays, the lot of advancement happening in all the field, including sleep medicine. PAP therapy still is the first line and gold standard treatment. Nowadays, we have very soft mask available nowadays for the betterment of the adherence and long-term treatment. Yes, ma'am.
Thank you, sir.
Sir, in addition to Dr. Tara's query, is there any separate bed like alpha or something like that? Is there any specific bed recommended for OSA?
So there is no specific bed at all. So we have a lot of sleep hygiene practices. In the case of insomnia, so Dr. Ramya will discuss about that. So briefly, there is a lot of sleep room to be calm, cool, quiet, and a lot of things. So Ramya madam will discuss about the all kinds of sleep aid which help in good sleep. Yes, sir.
Pulmonology ready, sir. Proceed.
Thank you very much, sir. Krishnavani, I'm seeing your slide. You can go to the full slide show and you can start presentation.
Just a minute.
Yeah. What? Take it. Krishnavani is one of the faculty of our Sleepmed IMA. 2 times she came as an examiner for our Sleepmed IMA final exam. So connected the practical examinations. So very nicely, she's a very good orator, clinician. He got a special training in sleep medicine in the St. John's Institute in Bangalore.
Class webinar conference.
All the delegates kindly mute your side. Madam Juliet, madam, please note, kindly mute all except the speakers. Thank you, ma'am. Dr. Krishnavani, you can unmute, you can talk.
Hello, sir.
Yeah, Krishnavani, yeah. Audible, yeah. Audible. Your slide is visible. Only thing is, slideshow is not there. No issue.
Yeah, I'm just trying to put it. I think there is some error that is coming. There's
full screen போடுங்க மேடம் full screen போடுங்க
வரல ஒரே நிமிஷம்
Yeah. Yeah, now it's fine. Good.
I'm so sorry for the delay. I had some issues in sharing the screen. So good evening, everyone. It is a pleasure to be part of the CME hosted by IMA Tamil Nadu State Branch and AMS. I'm excited to share my insights on sleep-related breathing disorder. Moving on to the presentation. So I will start with the case. So this is a 45-year-old male who's diagnosed with hypertension, visited our sleep clinic with complaints of snoring, witnessed apneas. The history of witnessed apnea was given by his wife during the night. So on further examination, patient's BMI was found to be 40 kilogram per meter square. Neck circumference was around 43 centimeter. So ENT examination revealed a DNS to left and Malampati was grade 4. So this is the broad sleep-related breathing disorder classification. So it is further classified as OSA, CSA, which is central sleep apnea, hypoventilation disorders, and sleep-related hypoxemia disorder. So CSA, the most common one is CSA with Kane-Stokes breathing. Next is CSA due to medical disorder, central sleep apnea due to high altitude periodic breathing, central sleep apnea due to medication substance abuse, TEXA, which is treatment emergent central sleep apnea, and primary central sleep apnea. Hypoventilation disorders, the most common one is obesity hypoventilation syndrome. The other rare ones are congenital central alveolar hypoventilation disorder and hypoventilation per se due to any medication, substance, or medical disorder. So owing to time constraint, we'll just stick on here with OSA, central sleep apnea with Kane-Stokes breathing, and OHS for discussion. So OSA, as Dr. Jayaraman sir told, so OSA is basically there is some problem which is happening in the upper airway, meaning there is anatomical occlusion of the upper airway. So the ventilatory thing per se is normal. So the respiratory effort is normal. So there is blockage only in the upper airway, meaning only the airflow is cut off. There will be persistent respiratory effort. So prevalence of OSA, it usually increases as the age advances. So usually less than 50 years, the prevalence is found to be 3 to 10%. Over the years of 50 years, the prevalence usually doubles. It becomes 9 to 20%. So what happens in OSA? So I'll just tell it briefly. So whenever you sleep, the upper airway muscle tend to relax. which causes soft tissue in the back of the throat to collapse. That is because of the either because of increased parapharyngeal fat or because of reduction in the cross-sectional pharyngeal area. This further leads to increased upper airway collapsibility. So which either causes complete cessation of airflow, or there will be 90% drop from the peak, with the patient will actually stop breathing. So this leads to apnea or hypopnea. So for us to call the patient is in apnea or hypopnea, there's a minimum duration which is 10 seconds. The maximum duration can go up to 15 seconds or 20 seconds. So if this happens, if there is a blockage in the airflow, so what happens? The oxygen will not go inside. So the patient will have intermittent hypoxia per se. There will be oxyhemoglobin desaturation, and because of this, patient keep on waking up in the night. So that will lead to sleep fragmentation. So cortical arousal. So if there is no oxygen signaling to any part of the organs per se, so that gives signal to the brain. So the brain will arouse. That is what we call it as cortical arousal. So again, the brain has to signal the muscles in the upper airway to open it, and then again the airflow goes in. So this cycle happens whole throughout the night. So it is happening all like weekly, monthly, and 365 days. It is completely happening all around. So this happens. So the brain does not go to deeper stages of sleep because it keeps getting signals as in all the organs are going for hypoxia. So this results in reduced slow wave sleep and reduced REM sleep. So this is pathophysiology in OSA. So as sir said, so the world is going towards precision medicine. So as in the sleep medicine. So now the one size does not fit all. And previously we used to see the AHI and prescribe CPAP for all the patients who's coming with obstructive sleep apnea. It is not like that anymore. So we have this OSA phenotype, which we call it as a palm scale. So so P is the peak that we call. So this comes in the anatomical risk factor. So this tells us how crowded and how collapsible your upper airway is. So peak rate is the critical pressure at which your upper airway tend to close. So there are other non-anatomical risk factors. So the A is the arousal threshold. So whenever there is an apnea happening, once the apnea starts, so all your upper airway muscles, they tend to release the airway narrowing, thereby again the normal breathing resumes. So before this happens physiologically by the pharyngeal muscles, the persons tend to awake prematurely. That is due to airway narrowing, which is called low arousal threshold. So these kind of people have a severe sleep fragmentation throughout the night, because of which the next day morning they tend to have they have a feel of unrefreshing sleep. They have morning headaches. All this happens because of this low arousal threshold. Next is L. L is the loop gain. Loop gain is how overtly sensitive is your ventilatory system. Meaning for any hypoxia that is happening, any carbon dioxide increase, meaning hypercapnia that is happening, how is your brain reacting to it? How is your ventilatory system reacting to it? Even for a small increase in CO2, sometimes it overreacts. So meaning it will make CO2 below the apneic threshold, so that patient will again stop breathing. So this is called a high loop gain. So loop gain meaning anything more than 1 is called an unstable ventilatory system. Anything less than 1 is considered normal. So that is called loop gain. This I'll be discussing in detail in central sleep apnea in my successive slides. Next is pore muscle responsiveness. So the upper airway muscle recruitment per se is very poor. So you can remember it as a palm scale. P is the peak rate, A is the arousal threshold, L is loop gain, and M is poor muscle responsiveness. OSA symptoms, I think everybody are very familiar with it. The most common one is the snoring, daytime somnolence, unrefreshing sleeps, and sedentary fatigue. So again, I would like to insist here that any symptoms varies between men and women. So men typically presents with snoring. You see the men, you know that patient is a OSA phenotype. Witness apnea, that will be told by the wife. So whereas when it comes to women, they still think that snoring and everything is a social taboo. They won't open up until you ask them. And the symptoms per se is different between men and women. So in women, what are the other symptoms that can happen secondary to OSA is nocturia, GERD, anxiety, depression, and most common one is insomnia. So now there's a new term called COMISA, which is called comorbid insomnia and sleep apnea. So that is any patient who is having a OSA has 60% chance of them having, any patient with insomnia has a chance of having. So diagnosis of SRBD. So whenever patient comes, you make sure you take a detailed sleep history. It usually takes 20 to 25 minutes for you to take a detailed sleep history. Start from which time the patient will sleep, what time they get up, once they go to bed, at like after how many minutes they sleep, whether they will get up in between in the night, after that they go to sleep only after 1 hour, or they get sleep only after 1 hour. All that history is very important. Again, the occupation history, whether they are which shift worker they are. The shift workers are the ones who are most commonly affected with insomnia or circadian rhythm disorders. So these are the most common history that you should detailedly take in any patient who's coming to your OPD. Also about the caffeinated beverages, at what time they take coffee and tea last. So that can also interfere with your sleep in the night. So next is the clinical examination. Look for height, weight, BMI, waist hip ratio, and neck circumference. And do a proper upper airway assessment, as sir said. Mallampatti grading tells us how crowded the upper airway is. Or again, look for nasal polyp, DNS, and inferior turbinate hypertrophy. And for pediatrics, the most common cause of snoring is tonsillar and adenoid hypertrophy. And the other common ones in adults are retrognathia and macrognathia. So also it is very important to list out the comorbidities that patient has. Most of the time, the comorbidity itself tells us what kind of sleep-related breathing disorder that the patient can have. So again, there are many scales which is available. The stop bank score is already discussed by Jayaraman sir. So again, the stop bank, it is totally of 8. So more the score, more the patient is likely to have OSA. Again, I would like to insist here that stop bank questionnaire per se, it just tells you the probability of the patient having an OSA, and it is not the definitely says that the patient has OSA. It is just a probability questionnaire. So anything more than 5 out of 8 means the patient has a higher probability of patient having a OSA. So same way is the ESS. So ESS is a 8 question Likert type scale. This tells us how sleepy the patient is. So this is totally out of 24. So anything more than 10 in this says that the patient is sleepy. So again, this is basically to tell if the patient is having a sleepy OSA and non-sleepy OSA. If the score is less than 10, doesn't mean that patient does not have a OSA, because we see a lot of non-sleepy OSA in OPD as well, with even more higher AHI and even more increased hypoxic burden. So going on to the case, after detailed examination, this patient is a known hypertensive on dual antihypertensive. Sleep hygiene was found to be poor. Stop bang was 7/8. ESS is 18/24. So we know the levels of sleep study. The gold standard remains level 1 sleep study. There are totally 4 levels in the sleep study. So the difference between level 1 and level 2 is, in level 1, we should, like in both, we should have a minimum of 7 channels, which is the EEG, EMG, EOG, either the thoracic or the abdominal belt. So again, the pulse rate saturation channel, the snore monitor we connect, and the EMG we connect in the chin as well as in the anterior tibialis muscle to look for any periodic limb movement disorder. So the only difference between level 1 and level 2 sleep study is level 1 will be done in-house in your sleep lab, will be video recorded, and it will be monitored by a sleep technician. Level 2, it is just similar to level 1. Only thing is it can be done bedside and even at home. It is not video recorded. Second, a sleep technologist will not be there to monitor the study. So level 3 is a 4-channel sleep study. So where you have only this airflow cannula, you connect either the thoracic belt or abdominal belt, and the saturation probe, which gives a value of the pulse rate and the saturation. So level 4, you either connect a nasal cannula or a probe, so which we are not using it anymore. So gold standard remains a level 1 sleep study. So diagnosis, again, it is conventional, we know, the PSG remains. The second is HSAT. HSAT is the level 3 sleep study, home sleep apnea testing. The modern ones, which is in market now, are wearable devices. You see, the watch you wear, that itself tells you that whether you have gone for a deep sleep. how efficient is your sleep, is everything. So we have a watchpad device that is now into the market, that also gives us the same reading, like with the N1, N2, N3, everything it says. Next are the biomotion sensors. You keep it is just like cloud based with the radar monitoring. It is coming. Next is monitoring based on the mattresses. So the mattresses are just kept under the mat, and it just by you turning around, it captures the body movement, and then it tells whether the patient is having a OSA or not. Next, the futuristic is definitely AI. The AI is already into the market, as in for the scoring and all, it is already doing its job. The sensitivity is 85 to 90%. It is scoring like how we do the manual scoring. The other things which is not yet come, but which are likely to come in the future, are speech recognition and 3D facial photography. So this is the raw data of obstructive sleep apnea. So if you see here, one second, this is the CAN flow. So this is the thoracic movement and abdominal movement. So down the abdominal movement, you see this is the saturation. So this CAN flow, if you see, this is the normal breathe in and breathe out. So later, if you see, there is definitely a reduction in the airflow that is happening. If this is considered to be normal, almost there is a 90% reduction, or there is complete cessation of the airflow which is happening here. But if you see the thoracic and the abdominal movement, it is still persistent. So this tells us that there is some issue only with the upper airway. The respiratory effort is found to be happening. So this is typical of obstructive apnea. So there's this cessation of airflow which is happening for more than 10 seconds. So minimal for you to call it as an apnea, or for you to score an apnea, the duration should be 10 seconds is minimum. Maximum can be 15, 20 or 25 also. Here the inspiratory effort remains to be persistent. So the treatment, the first is weight reduction. So tell the patient to do a brisk exercise every day for 45 minutes to 1 hour. Positional therapy, avoidance of alcohol. So primary treatment is positive airway pressure based on whichever mask or mask fit, or whichever the mission they are comfortable with. After discussing with the patient about what disease they have, you give a proper counseling on what are the pros in using the CPAP, and what are the expected complication or expected side effects that can happen in the 1 week of starting the CPAP, when they should come back to you, and also about the financial things, because once the patient has to buy the machine or get it for rental, it's going to be little expensive. And the most common question they ask us is, ma'am, how many months do we have to use it, or how many days do we have to use it? You have to convince the patient saying they have to use it lifelong. So there it ends. You say that they'll be like, ma'am, lifelong, and then there only it goes. So it is very, very difficult. So whenever you're starting the patient on a PAP therapy, make sure you spend some time with the patient, explain them detailedly everything for 20 minutes, 30 minutes, and then if possible, you give a CPAP trial in your hospital itself, in your OPD itself for 20 minutes, 25 minutes, so that they will first get accustomed to that mask, mission and everything. And if they are having any issues there, you can try to troubleshoot it. So again, the treatment initiation depends on the presence of comorbidities. If it is only an OSA, start with a PAP. It can either be a manual CPAP or an auto CPAP. But if the patient has an underlying COPD, type 2 respiratory failure, so here the device of choice would be a BiPAP. Next, OHS for 70%, they will respond to CPAP, but 30% of them who has hypoventilation, it is better to start them on a BiPAP. Again, as I said, the management of side effects of PAP is very, very important. It is very, very important. So usually the side effects, the most common side effects, it happens as soon as they start using. So make sure you call the patient for review at the end of 1 week itself, and try to correct the side effects of the CPAP. So most common are nasal congestion. If patient has any DNS or polyp which is disturbing them, then give them nasal spray or something, and then ask them to put the PAP. They can also complain of a dry mouth or throat. In that time, you can tell the patient to use a humidifier. If patient is having a aerophagia, then you have to convert the mask to a bigger mask. Then eye irritation, that is because of pressure which is going up the air. Make sure the leak is not there and adjust the nasal mask accordingly. Sometimes some patients can be claustrophobic, so you have to make them accustomed by wearing the mask like first 15 minutes, then 20 minutes, initially starting from the morning. Once they are okay, then you have to go to the night and tell them to use the mask properly. So monitoring of CPAP is again a very, very challenging task. So before we tell the patient to bring the whole machine, and we have to remove the SD card from there, put it in the system, and then get the report. So now it is no longer like that. So whenever the patient is purchasing a machine, so they can download this app. So this tells us like how good they slept, how good they are using, how is the mask fit, how is the AHI and everything. So it also tells them out of 100% how good is the usage. So this will be kind of motivation to them to use the CPAP. So next is the AirView. This is the cloud-based system that is recently come in. So this is like from your system, whenever they are purchasing, they have the serial number, DL number, just have to enter and get the name of the patient in your system itself. So you can sit in your place, and wherever they are in the world, you will be able to access the report, like meaning whether they are using it, how much time they are using, how's the leak, and everything you will be able to assess from your chamber itself. So next is drug-induced sleep endoscopy. I'm not going in detail. I think Dr. Saktish will be going on to it in little detailedly. So DICE is basically a sleep endoscopy. This we give a propofol because propofol usually mimics the natural sleep, so we tend to give the propofol and then look at the OAT classification. I think everyone is most common of the velum, oropharynx, tongue, and the epiglottis. At what level is the obstruction they will be seeing? Accordingly, they will be planning for the surgery. But from our perspective, why we tell is if the obstruction is at the level of epiglottis, so they might not be able to tolerate the CPAP. So epiglottopexy and any surgery, once it is done only, will be able to use the CPAP. So next are mandibular advancement devices. So this is for mild to moderate OSA and people who are refusing to use CPAP therapy. You can still give them mandibular advancement devices. So I recently had a patient who had a severe OSA, but he completely refused to use the CPAP even after some 8 to 9 trials in OPD. So later I had to put him on a mandibular advancement devices, and he's doing so good now. The HA reduction is not great, but it is 50% reduction is definitely there with the use of mandibular advancement devices. So these are the surgical procedures. The most common one is UPPP, then tongue size reduction, maxillomandibular advancement surgeries. I'm not going in detail. So next is a myofunctional therapy exercise. There are totally 8 to 10 exercises which are available. This is available in the YouTube itself. So any patient who's coming to you with the OSA, you are diagnosing the patient is having a moderate OSA, severe or mild OSA, please teach them this exercises, train your technologist, or you can even send them the YouTube videos of it. So this basically improves the strength and the endurance of the upper airway, pharyngeal and the tongue muscles. So this is Excite device for snoring and OSA. We are not using it much now. So next is hypoglossal nerve stimulation. This basically stimulates the hypoglossal nerve, activates the genioglossus muscle, which opens up the airway during sleep. Again, this is reserved only for patient who is not tolerant to PAP. So next are the drugs. There are so many drugs that has come onto the market now. GLP-1 agonist, tirzepatide, semaglutide, everything is coming. So, so we have some trials like Sermon trial that has recently come in, which says that with use of tirzepatide, there is reduction of 60% AHI from the baseline, and 20% of weight reduction is also there with this. So which is indirectly helping the helping the OSA as well. So these are the consequences of untreated OSA. The most common comorbidity or the complication is hypertension. So anyone who's coming to your OPD with resistant hypertension or refractory hypertension, 85 to 90% of them are bound to have an obstructive sleep apnea, and workup for OSA is very much mandatory. So next is MI, arrhythmia, stroke, diabetes, insomnia. I told about the COMISA, and anyone who's on any critical job, who's a driver, pilot. So when they are driving and they sleep when they drive, so there is a chance that it can even endanger the life. So going on to case 2. This is a 62-year-old male who's a retired teacher with known history of hypertension, ischemic cardiomyopathy with EF of 30% and diabetes. So this patient had symptoms of fragmented sleep, frequent awakenings in the night, witnessed apneas without effort. This was reported by the wife. The patient also had morning headaches. There was a poor concentration and memory. On further examination, BMI was 25. Patient was not obese. There were signs of LV dysfunction. Neurological examination was found to be normal. So this patient was found to have a central sleep apnea. So unlike obstructive sleep apnea, where there is only an anatomical occlusion of the upper airway, here the brain forgets to send signal to the respiratory muscles to breathe. So there will be impaired ventilatory response to the stimuli. So the prevalence of CSA is only 0.9%, of which 50% of them is more common in heart failure. Symptoms and risk factors, choking and gasping will be the very first symptom. It will be very, very disturbing for them in the night and it will be very scary also. Next, the sleep disturbance because of the choking, gasping episodes that's happening throughout the night. So generalized tiredness and fatigue, inability to concentrate. So, and what are the most common risk factors pertaining to central sleep apnea? Most common CNS disorder is the stroke. In serious congestive heart failure is more common. OHS is also one of the risk factors for central sleep apnea. Next is neuromuscular disorders and chronic opioid use. So what is central sleep apnea and what happens? So there will be reduction or cessation of the rhythm generator, which is in the brainstem, which leads to reduce in the ventilatory output or total absence of the ventilatory output during sleep. So why it happens is, I already spoke about the loop gain. The same mechanism applies here in the central sleep apnea as well. So if there is any ventilatory disturbance, meaning if there is hypoxia that is setting in or hypercapnia that is setting in, how is your ventilatory system responding to that, which is called the loop gain. So anything more than 1, we call it as an unstable respiratory system, ventilatory system. Anything less than 1 is considered to be normal. So what happens is, so we have 3 components in the loop gain. One is controller gain, mixing gain, and plant gain. So controller gain is how sensitive is your chemoreceptors pertaining to any change in the O2 and CO2. Next is the plant gain. So how efficient are your lungs to remove the CO2 efficiently? And mixing gain is the time required for the change in CO2 or the alveolar CO2 to reach the chemoreceptors. That is the mixing gain. I know it's a little difficult, but I'll try to put it easy in the next slide. So if you see here, this is the awake CO2 level. We know during the sleep, there will be increase in the CO2. So the difference between the sleep CO2 and the apnea threshold, we call it as a decreased CO2 reserve. That's called the CO2 reserve. So whenever there is a disturbance which is happening, so this is the sleep CO2, this is the awake CO2, this is the normal breathing. So whenever there is a disturbance that is happening here, what happens is the ventilatory system overreacts to it. Basically, what it happens, it washes out the CO2 below the apneic threshold. So apneic threshold usually lies somewhere like 5 to 6 millimeter down the awake CO2 level. So whenever the carbon dioxide goes below the apneic threshold, your breath will stop. So here, due to the disturbance, what happens? As you see here, it is washing out carbon dioxide more because it is overtly reacting to the hypercapnia. So once, if you see here, it is going below the apneic threshold, the apnea, the cessation of airflow is happening here. So during this thing, when the cessation is happening, the CO2 again starts getting built up. So again, it is getting built up. Again, one more disturbance is happening. Again, it is going down. So it is basically sensing there is a little increase in the CO2. It is over sensing and putting the CO2 below the apneic threshold level, which is causing the central sleep apnea to happen. So again, it is washing out. So this is the typical crescendo, decrescendo type of breathing we call. This happens in the Kane-Stokes respiration. These are the types of CSA. We classify it as non-hypercapnic and hypercapnic CSA. So non-hypercapnic, most common medical condition related, high altitude or idiopathic. Hypercapnic CSA or OHS, congenital central sleep apnea, CNS disorders associated like stroke, Next, the neuromuscular disorders, opioids, excessive opioids use, history of trauma, and next is DEXA, that is treatment emergent central sleep apnea. So again, for any central sleep apnea, level 1 remains the gold standard. Per se, if patient is having any comorbidities, always go for level 1 sleep study. If you think, you see the patient is OSA phenotype, you're like kind of 80% sure the patient will definitely have an OSA. So those kind of patients, only you go for a level 3. The patient can have a hypertension, anything more, any other comorbidity is there, like patient has a history of CVA or history of CAD, always go for a level 1 sleep study. So again, this is the raw data for central sleep apnea. If you see here, this is the CAN flow, and there is definitely a cessation of airflow which is happening here. So unlike obstructive sleep apnea, if you see the thoracic and abdominal well, there is complete absence here also. So you can see 3 straight lines here. So this is happening in the thoracic and abdominal because you're not getting signal from the brainstem. So this is the central sleep apnea. So again, when will you call the patient has a central sleep apnea? If there is more than 5 central apneas or hypopneas per hour of sleep, with more than 50% of events being central, then you call that patient is having a central sleep apnea. So again, for a CSA, CPAP is the first line therapy of choice. There is no set titration protocol. Next comes the ASV. Next is BiPAP. So, whenever you go, you confirm the patient is having a CSA. So again, between ASV and BiPAP is a very difficult choice. So look for the patient heart function, EF. If the EF is more than 45, go for ASV. If it is less than 45, go for BiPAP. So ASV, what it does, it basically senses the movements breath by breath. And whenever the patient is not breathing, it supports by giving the breaths only during that time, which you see here in the picture. Next is the BiPAP mode. Make sure you use the BiPAP in the ST mode. This is especially for patient whose EF is less than 45%. So the alternative modalities are oxygen, which reduces the chemosensitivity. Next, the use of acetazolamide, which basically induces the metabolic acidosis, thereby reducing the loop gain. Next is the phrenic nerve stimulation. Whereas in OSA, it is hypoglossal nerve stimulation. In CSA, it is phrenic nerve stimulation. So this basically activates the diaphragm and restores the breathing. So this is EERS, we call it. Basically, this is the EERS tubing here. This prevents the exhale air from being vented out through the CPAP mask. Basically, it supports by retaining the CO2. And there are all the Z medication that is available. It is still under trial. So there is no clear-cut indication for prescribing this in the central sleep apnea. Going for the third case and the last case. So this patient is a 55-year-old obese female who's a hypertensive, diabetic, admitted with complaints of shortness of breath, which was progressive since 1 week. So on arrival, the pulse rate was 102 per minute, saturation was 85% on room air. On auscultation, there was bilateral occipital bronchi and bilateral pitting pedal edema. So the ABG revealed pH of 7.35, PCO2 of 55, PO2 of 58, and bicarbonate of 30. So this patient was started on intermittent and overnight BiPAP with 2 liters of oxygen with a BiPAP setting of 14:7. So on further assessment, this patient denies prior history of any obstructive airway disease, but has history of snoring and witnessed apnea. BMI was 32 kg per meter square, Mallampati was grade 3, and ESS was 12/24. So this patient was likely to have obesity hypoventilation syndrome. So the prevalence is roughly 0.4%. But this patient, roughly 90% of this patient with obesity hypoventilation syndrome have concomitant OSA, of which 73% of them will have a severe OSA. So 30% of them will have a non-obstructive sleep hypoventilation. So this is the diagnostic criteria of OHS by AASM. So which says that there should be daytime hypoventilation. That is, in your ABG, the PaCO2 should be more than 45 millimeter of mercury. Obesity, the BMI of more than 30 kg per meter.
Record your name and reason for calling. I'll see if this person is available.
And hypoventilation, which is not due to other lung, chest wall, or neuromuscular devices. So any patient with the OHS has higher prevalence of cardiovascular morbidity, increased hospitalization, and augmented mortality. So this is what hypoventilation was defined as. So any increase in the PaCO2 in the form of end-tidal CO2 volume or transcutaneous CO2, there should be more than 55 millimeter of mercury for more than 10 minutes. So the PaCO2 should be more than 55 millimeter mercury for more than 10 minutes. Also, there should be increase in the PaCO2 of more than 10 millimeter of mercury compared to awake supine value to a value of more than 50 millimeter of mercury for more than 10 minutes. And the most important and clue giving is the elevated serum bicarbonate level. Just the serum bicarbonate tells us if the patient is having an OHS or not. This is almost 90% sensitive, elevated bicarbonate levels per se. So phenotypes of OHS, one is OHS with concomitant OSA, second is OHS with predominant hypoventilation. So the most common one is with the concomitant OSA. So most of these people usually respond to the CPAP per se, that is 70%. So OHS with predominant hypoventilation. So those kind of patients, they usually will need a BiPAP. So pathophysiology of OHS, we know the patient is very obese. BMI usually you see it will be more than 35 or 40. So there will definitely be reduction in the lung volume, reduce in the total lung capacity, reduce in the FRC, and hypoxemia or hypercapnia can be there per se. The mechanics per se, it is kind of restrictive for them. So next is leptin. So this is the very latest theory. So leptin usually, it regulates the appetite and stimulates the ventilation. So here, if there is a leptin resistant, that per se can cause a hypoventilation here. So next is the respiratory muscles. So we see the MIP and the MEP pressures are usually reduced here. The OSA, I told already, any patient with OHS, definitely 90% of them has an OSA. Of the 90%, 73% are found to have severe OSA. So this cessation of airflow during the apnea per se will again cause a disrupted alveolar hypoventilation, which reduces the HCO3 clearance, because of which your serum bicarbonate level is increased. This per se will blunt the ventilatory response. So treatment, lifestyle modification, ask the patient to be in a strict diet and exercise. So you tell them to be in a calorie restricted diet of 1,000 to 1,200 kilocalorie per day, which consistently produces the weight loss, averaging 8% over 6 months. Again, aerobic training, either separate aerobic training or with the resistant training. Next, combining both, meaning a patient should be in the diet as well as they have to go for an exercise. If you combine both, the weight reduction is even more better. So the goal here in OHS is 25 to 30% of the weight loss. So pulmonary rehabilitation in OHS. So this is basically, this addresses the deconditioning. So we know OHS patient, because of the obesity per se, they won't able to mobilize. They have severe functional limitations because of that, and muscle weakness. So using only CPAP will definitely not reverse it. So pulmonary rehabilitation is very useful in it. So it is either a 6-week program or a 3 months program. It can either be weekly 3 days or every day for 6 weeks. So that basically improves the muscle strength, muscle endurance. Also, this improves the 6-minute walk distance as well. So types of therapy, CPAP is the preferred therapy in patients with OHS. Next is the BiPAP. Any patient who's having underlying COPD with it, or this patient is having a hypoventilation phenotype, always switch to BiPAP for these patients. Also, if patient is not responding to CPAP, or you're doing a manual titration, you are seeing the CPAP values are going more than 17 or 18, please tell them to use a BiPAP. So this NIV is for patients who is coming to your ER. So most of the times, almost I can say 60 to 70% of the time, we diagnose most of these OHS people only in the ICU. So they will be on acute on chronic hypercapnic respiratory failure. So these kind of patients, when you discharge them from the hospital, make sure you discharge them with the BiPAP. Later, after 3 months or 4 months, once the carbon dioxide, everything has been normal, is coming to normal, later you have to do the sleep study and then decide whether you have to continue the patient with the BiPAP, or you can see if you can wean them down to CPAP. So summary, OSA CPAP remains the gold standard of choice. Palm scale in OSA has a multifaceted pathology. As the world is going towards the precision medicine, Next, medications such as terciperidine, which is a GLP-1 receptor agonist, shows promising result in improving metabolic control and promoting weight loss, which indirectly reduces the obesity severity. So, indicated in OHS patients with type 2 respiratory failure or any patient who already had a history of COPD per se. Thank you. So, any questions?
For the wonderful, crisp and clarity presentation of sleep disorder breathing, of various kind of with the case presentation, with the illustration of 3 cases. You shown beautifully all the variety of cases, plus the sleep apnea. In that OSA and central sleep apnea and obesity hyperventilation. So what's the treatment modalities? When to give CPAP? When to give the BiPAP? When to give the ASV? With the EF ejection fraction more than 45, we go for the ASV. Less than 45, in the case of central sleep apnea, you go for the BiPAP. So beautifully, you currently explained. This topic is open for discussion. Any queries, please unmute and ask the questions to Dr. Kesamani.
Dr. Kesamani, done extensive coverage. Well done. Keep it up.
Thank you, sir. Thank you.
Only one question, madam, on behalf of all the senior or junior family physician.
Yes,
like in diabetes, we have HbA1c because for the better control of diabetes, they do HbA1c. Similarly, do we have in OSA or sleep disorder? Similar marker.
Marker?
Amma, இப்போ HbA1c diabeticல பண்றாங்க இல்லையா?
ஆமா.
அதே மாதிரி OSAவுக்கு ஏதாவது ஸ்பெசிபிக் மார்க்கர் இருக்கா? நல்லா
We are working on OSA and genetics, sir. We are coming up with markers. So probably in few months we'll be telling you. We are just looking on to the markers, which is pertaining to the Asian phenotype.
Okay. So one more question by all the general practitioners: is obesity a must for diagnosis of OSA? OSA patient எல்லாமே obesity இருக்கணுமா இல்லாம இருக்கலாமா?
இல்ல, we have obese OSA, non-obese OSA also. So obese phenotype வந்து பார்த்தாலே வந்துட்டு we know those patients will have an OSA. That's because of basically the upper airway collapsibility, meaning extra parapharyngeal fat and everything. But this non-obese OSA வந்து இருக்கிறவங்களுக்கு வந்து we have to see if patient has any upper airway abnormalities இருக்கான. Basically any DNS or polyp or any is like in the tongue you see for macroglossia or you look for any tonsils, adenoids, all that needs to be checked if any patient who's non-obese is coming. Also ask them if the patient is having any cardiac comorbidity. If the patient has a cardiac comorbidity, always rule out a central sleep apnea by doing a level 1 sleep study.
Well done, madam. Thank you. Only a last question regarding polycythemia and OSA patient.
Yes, sir.
எவ்வளவு percentage? Is it common or less common? Polycythemia in OSA.
நான் இப்போ வரைக்கும் பார்க்கல, sir. I have not seen.
Okay. Thank you. God bless you.
Thank you, sir. Thank you.
If there are no questions, we'll move on to the next presentation. Thank you, Kesamani, for the wonderful, crisp and clarity presentations. Very nice of you. So, thank you. We'll move to the next presentation. May I invite Dr. K. Saktis, MS ENT. He is a head and neck surgeon. He is having his own center called the Hopkins No Snore Clinic at Tambaram. He is a very nice ENT surgeon. He is mainly expertise in sleep apnea surgery in Chennai. He is practicing in the Tambaram, and one of the underwent a special training program in various leaders of sleep apnea surgery. So may I welcome to talk on the surgical management of obstructive sleep apnea. Over to Dr. Saktish. Saktish, the stage is yours. Yeah.
Am I audible now, sir?
Audible. Thank you. Nice, nice.
Are you able to see my slide?
Yeah. Yeah, slide is visible. Go to the first slide.
1 second, sir.
Yeah.
Second. Okay. Okay. So, good evening, everybody. It is wonderful to see you all here. Thank you, IMA Tamil Nadu State Branch and its leaders for organizing such a fantastic meeting today. So it is really heartening to see more than 700 participants. Fantastic work, AMS team led by Dr. Nirmal Frederick. Thank you for this invite, Dr. Jayaraman sir. So I wish all of you a very happy World Sleep Day. It is said that sleep is the golden thread that links a man, and that is the one which separates, it ties a man to his health. If this golden thread is broken, you invariably land up in some kind of disease or the other. So that is the importance of sleep, and that's why we are all gathered here to know more about sleep and the problems associated with it. And obstructive sleep apnea, has been beautifully explained by Dr. Jayaraman sir and Krishnaveni, is one of the most important diseases that affect the quality of sleep in our people. And why it is important? Why are we concerned? Why is IMATNSB taking so much of effort? Is because of this recent landmark study by Ames Bhopal. Previously, we used to believe that OSA is prevalent in 10 to 12% of adults. That used to be the Western literature. We didn't have any prevalence study of our own. But then there was a fantastic study conducted by Ames Bhopal, which was published 2 years ago, which revealed a startling 32% of prevalence among Indian adults who had moderate to severe obstructive sleep apnea. And the worst thing was most of them have not been treated, and most of them are not even aware that they have this problem, and most of them are not aware, like Jayaraman sir sonna madri, they still live thinking that they are nalla korata vittu thoongittu irukkranga. So that is the pathetic situation which is prevailing in our country, and we are looking at 45 million Indians who are possibly suffering from this disease, and they require treatment from doctors like us. And why it is important? See, if the patient believes that obstructive sleep apnea is not a problem, கொரட்டான்றது ஒரு பிரச்சனை இல்லைன்னா, see, this gentleman here is a doctor, he is a pediatrician. Look at the caption that he has put on Instagram: me after treating tonsil and adenoids without surgery and nasal steroids. See, in fact, surgery and nasal steroids are the two most important form of treatments which are advised for adenotonsillar hypertrophy. And here you have a doctor. See, if it is some random YouTuber, you can understand. Anybody can go and post anything on an Instagram. Here you have a pediatrician, and I very sorry to say that I inquired about this doctor, and I found out to my shock that he was the president of the IAP of his city, a very educated city. I don't want to name it. And look about the myth that is prevailing even among our doctors. So even doctors, we don't have proper idea about it. This pediatric gentleman, if he goes around and telling that adenoid and tonsil surgery is not required, and then what are we doing for this society? So that is the main reason why it is important. Before we kind of do anything for the society, it is important, I think, that we should educate ourselves with proper knowledge before we go out and treat this 45 million Indians who require treatment from us. So, and this is the very basic thing that we all want to prevent. Even if we don't achieve anything great by treating obstructive sleep apnea, this is one simple thing that we can definitely prevent by properly diagnosing. So here you obviously have a driver who is suffering from severe sleep apnea. He has fallen asleep at his wheel. And the worst thing of this incident is that the poor gentleman sitting behind, he doesn't have any problem. It is not his fault. It is not his disease. But the consequences do affect him. Imagine this was a bus. Imagine this was a train. The consequences could be even more severe. So that's why we are all gathered here, because this is a very important condition. It can affect sleep, which is the basic foundation of health. So it is very important that as doctors, we need to be aware of what is right and what is wrong, what is truth and what is myth. See, we still, as doctors, sorry to say that we still have a lot of myth about this condition. So it is important that we get our facts right first before we advise our patients. So when it comes to surgical management, why surgery? So as already pulmonologist has beautifully explained what is the treatment, how to diagnose and all. See, if you go 5 to 10 years back, usually when there is a discussion happening on obstructive sleep apnea, it will always be a pulmonologist versus ENT surgeon. They'll always they'll have debate on whether CPAP is better or surgery is better. If you had closely followed the talk of previous two speakers who are pulmonologists themselves, now you would have understood that we have moved away from those ignorant ages where we used to fight that whether CPAP is better or surgery is better. Now we have moved on to an age of enlightenment where we understand that obstructive sleep apnea is quite a complicated condition. There are a lot of factors involved. So it is not like one size will fit every patient. So you have to customized treatment for each and every patient, and that's why you see pulmonologists talking about maxillomandibular advancements procedure, drug induced sleep endoscopy, and me saying that it is not that surgery is going to treat all of your patients. So still, uh, why and where surgery is indicated in obstructive sleep apnea? So obstructive sleep apnea, to give you an overview, it is a very the common thing is there is upper airway collapse. The upper airway intermittently collapses during sleeping. Why it can collapse? There are four factors which are mentioned. One is there could be some upper airway abnormalities which are making the upper airway not so patent, which is resulting in collapse. Number two, there could be some neuromuscular incoordination. See, there are dilatory muscles in the upper airway, there are constrictor muscles in the upper airway. When there is an imbalance between the dilators and the constrictors, it can result in an unstable airway, which can invariably collapse when the sleep associated muscle relaxation happens. So that is neuromuscular incoordination. And third is what, like the previous speaker was explaining, there is a hypersensitive airway regulator which results in what is called as a loop gain, which triggers airway unstable airway. And finally, there are people who have inherently low arousal thresholds. They have a very low threshold for getting awakened from their sleep. So that is another factor. So we have well defined four different reasons why somebody could be having obstructive sleep apnea syndrome. And it's not like patient A will only have anatomical airway a problem, patient B will only have neuromuscular incoordination, and patient C will only have loop gain, and patient D will have only low arousal threshold. In one patient, you can have a combination of all these four factors. So the obvious thing here is we have to adopt a holistic management when it comes to management of obstructive sleep apnea syndrome. So when it comes to surgery, why a surgery is needed? So the one of the important thing, as the previous speakers mentioned, CPAP continues to be the gold standard when it comes to treatment of obstructive sleep apnea, meaning it is able to help most of the patients with this condition. But then the most important thing, which even all of us agree, is that the long-term compliance of CPAP therapy is variable. Most of the published percentage is between 30 to 50%. That is, only 30 to 50% of patients who have been prescribed CPAP for their obstructive sleep apnea continue to use it in long term. And number two, most of the younger patients these days, even when you bring up the topic of CPAP, they kind of say, how am I supposed to wear a machine? So it's patient's preference. Younger patients usually don't prefer PAP therapy as a treatment option. And third important thing, even you see, there are, Dr. Jayaraman was talking about, somebody brought up this important question of how comfortable it is to wear and use a CPAP on a long term. And Jayaraman sir beautifully explained that nowadays we have a very minimally intrusive devices like nasal pillows. But for these kind of minimally intrusive nasal pillows to work, the very basic requirement is that you should have a patent nasal airway. If your nose is completely blocked, then you cannot use all these minimally intrusive nasal pillows and such devices. So most common reasons why people don't use CPAP is like simple factors like their nose is blocked, their tonsil size are huge, they have some fixed anatomical obstruction, which is causing the CPAP to use a lot of high pressure. See, basically, their airway is offering a lot of airway resistance because there are fixed anatomical factors which are offering this airway resistance. Unless you take out this airway resistance factor, the CPAP is going to use a lot higher pressure. Higher pressure means uncomfortable usage for the patient. So the important reason why people are non-compliant to CPAP is anatomical factor. So that is another role where surgery comes into play. And as mentioned by the speaker, CPAP is not always effective in all the patients with obstructive sleep apnea. For example, if the patient has a gross tongue-based collapse, a craniofacial abnormality, or an epiglottis collapse, these patients are not ideal candidates for obstructive the PAP therapy, because they will simply not be helped and they will not tolerate PAP therapy. And these are the reasons, like CPAP, I was talking about CPAP compliance. These are the common reasons, like they find it inconvenient to wear it, their difficulty in nasal breathing, mouth dryness. All these things are easily addressable conditions. So the one of the important indications for surgery nowadays is like, one, if you have a clear anatomical reasons for surgery, you can take surgery as a curative option for obstructive sleep apnea. And even if the patient requires PAP therapy, the surgery's role is improving the compliance of CPAP, which I think is the biggest and most important indication, because with 30 to 50 percentage compliance, even if CPAP is the gold standard, if the patients are not using it, then it's not going to be of any use from the practical point of view. And another thing to consider is like sleep apnea is a spectrum of disease. It's not a, like all of them have the same level of problem. So you have what is called as simple snorers. They have like, see, you have people with normal breathing on one side, some people who occasionally snore, some people who regularly snore, and there are people who just complain of tiredness. You do a polysomnography, no matter whether it is level 1, level 2, level 3. If you do a polysomnography for all these patients on the left side of the line, you will find that their polysomnography is normal. So an upper airway resistance patient will come to you with a lot of tiredness. He will feel depressed. He will complain of headaches and vague complaints. The Kaikal Talavali syndrome madri, they will present. Young patients complaining of all these things with no apparent reasons. And if you do polysomnography, it will be normal. And these patients are what we call it, they'll have history of snoring also. And these patients are called as upper airway resistance syndrome. So what would you do? You cannot prescribe CPAP for these patients, but these patients are the ones who have to be evaluated further. They might be having easily addressable conditions like some anatomical factors which are contributing for their nose block, increased airway resistance. This increased airway resistance, if addressed properly, can completely solve the problems and complaints for the patient. See, the CPAP we generally conventionally prescribe only for the mild, moderate, and severe sleep apnea patient. We don't prescribe CPAP for upper airway resistance, regular snoring, and all. So for these patients, the surgery is could be a solution for all these patients. So coming to contemporary surgeries, so there was a time, if I ask the most of the doctors here about what surgery that you know of that is used for treatment of obstructive sleep apnea, I think most of you would answer UPPP, that is uvulopalatopharyngoplasty. But let me answer you that UPPP is one of the obsolete surgeries. Nobody would advise or perform a UPPP now. So there have been so much of change that has happened in the field of sleep apnea. Now we live in an era of precision and evidence-based medicine. We have better understanding of the condition. We have less invasive, target-oriented, and tailor-made procedures for the particular problem that the patient is suffering from. And of course, we have better technology in the form of like coblation, robot. We have robotic surgeries. We have piezoelectric devices which work on based upon ultrasound technologies. We have exciting suture materials like barbed wire sutures which make suturing in inaccessible areas a breeze. And of course, one of the major problems associated with obstructive sleep apnea surgery used to be the severe pain that the patient has to endure. But nowadays we have better pain management tools. So the contemporary surgery has become more effective and less invasive. And if I can say more, it has become more target oriented for the patient. So thereby we are improving the results leaps and bounds nowadays. So when it comes to surgery, so before we discuss what we do for the patient, we have to understand what we are trying to understand. See, the obstructive sleep apnea, essentially it is seated around this area, that is the upper airway. So that is the oropharynx. The oropharynx is a structure exclusive to human being. No other mammal has a oropharynx. The oropharynx has evolved because we adopted an upright two-legged posture. So only the humans snore. That is one trivia if you are not already aware. So this oropharynx is the site of obstructive sleep apnea. And when it comes to the anatomical obstruction, we classify into two things. One is called as a static obstruction and another is called as a dynamic obstruction. What do we mean by static obstruction? See, the static obstruction is something like, see, you have a deviated nasal septum, you have a nasal polyp, you have a huge tonsil, you have a huge lingual tonsil hypertrophy. These are all static obstruction. They are always there, whether the patient is awake, whether the patient is sleeping, they are always there. If you ask the patient will say that I have nose blocked, I have some kind of blocked sensation in the throat. That is always there, irrespective of whether the patient is awake or sleeping. But coming to the second part, the dynamic obstruction. The dynamic obstruction is the obstruction that happens during sleep. When the patient goes to sleep, all these upper airway muscles, they kind of relax. When this relaxation happens, there is a set of dynamic airway collapse that can happen. That is what we call as dynamic airway collapse, and those things are called as dynamic factors. So when we, as surgeons, when we are trying to address, we are trying to address the possible static obstructions and also the dynamic obstructions. So when it comes to the airway obstruction, there are a lot of studies which have confirmed that the multi-level airway obstruction, it is not like it is at one level, only the palate is at the fault, only there is problem at the nose. That is extremely rare. Only 20% of patients have single level obstruction. Most of these patients with obstructive sleep apnea, they have multi-level airway obstruction, and around 30% of these individuals have all three. See, when it comes to obstructive sleep apnea, the nose is considered one level, then the structures behind the soft palate are considered retropalatal structures, and those structures in the posterior end of the tongue, they are all called as retrolingual structures. So if somebody has collapse at all these three levels, they are called as multi-level airway patients. So 30% of patients with obstructive sleep apnea have multi-level airway obstruction is present in all those patients. So like I was explaining earlier, these are the static obstructions like a deviated septum, turbinate hypertrophies, polyps, huge tonsils, adenoid hypertrophy. So, and then the diagnosis of these static obstructions are pretty straightforward. You do a nasal endoscopy, you do a CT scan for the paranasal sinuses, you do a proper clinical examination. You can easily pick up all these static obstruction. You don't have to have special tools. Even if you put a torch in your primary care physician level, you can pick up most of these static obstructions and thereby avoiding a lot of unnecessary hassle for these patients. And when it comes to diagnosis of dynamic upper airway obstruction, it gets a little bit technical. So you need to have the help of a specialist who can do this for you. So generally we do two things. One is called as a drug-induced sleep endoscopy and the other is called as dynamic MRI. So the dynamic MRI is where the patient kind of sleeps inside an MRI console and they kind of record what happens when the patient sleeps, and that is supposed to give a good understanding of what happens during the sleep. These dynamic airway obstruction can be diagnosed, but the problem is, all of us are aware about the problems of MRI. It is very difficult to even, a lot of people have difficulty even tolerating the sounds associated with MRI. So it is very difficult for any patient to sleep inside an MRI, except for the patients with very severe sleep apnea with lot of excessive sleepiness. Most of the patients will find it difficult to sleep inside an MRI console. So we generally don't use dynamic MRI as the procedure of choice. We generally tend to use this drug-induced sleep endoscopy. It is like many argue that it is not natural sleep. We are giving some drugs. It is not artificially induced sleep, but lot of research has been conducted and it has been found out, like the previous speaker was telling, that propofol, it is the closest that you can get to a natural sleep. It is a very short acting agent. It does not affect the respiratory reflexes. So the propofol is what we use, and we also use what is called as a bispectral index. Short form is the BIS. So BIS monitoring will exactly tell you at what level the patient is sedated. So you will exactly know whether the patient has been too much sedated or not been sedated at all. So we generally keep the levels at 65 to 75, which is supposed to be the level which mimics natural sleep. And we do classification and grading by what is called as a vote classification. So these are the setup where kind of the patient is given drug, multiple things are monitored, and the patient is sleeping and the ENT surgeon is performing an upper airway endoscope with a flexible scope. The flexible scope nowadays are very thin. The endoscope that we use in our center is only 2.7 millimeter thickness. So even if we don't give any local anesthetic, also the patients are able to easily tolerate, and they are not aware that the endoscope is being passed inside the nose while they are sleeping. So this is the ward classification. See, basically, we take each level. The velum is the area behind the posterior end of the nasal septum. So that is taken as V. And the O is the point where at the oropharynx level, the tongue obviously means the posterior part of the tongue. We are only interested in the posterior part of the tongue, not in the anterior part of the tongue, because the posterior part of the tongue is which contributes for obstructive sleep apnea. And E stands for epiglottis. Each structure, while we are doing this endoscopy, we will observe for 2 cycles. By 2 cycles, I mean that the patient will pass through a cycle of apnea, that is the breathing completely stops. After a few seconds, the patient starts snoring, and after some time, they go for another episode of apnea. So at each level, we are supposed to observe for 2 cycles: apnea, snoring. So 2 cycles we observe, and what do we note is whether there is any obstruction. If there is any obstruction, is it complete obstruction or a partial obstruction? And also the type of obstruction. The obstruction can be an anteroposterior obstruction or a lateral obstruction, or sometimes it could be a combined obstruction. All these details are noted at each level. And why this is important? Because the treatment can widely differ based upon the type and the degree of collapse that the patient is having. So this is a sample video of what we call as a DICE polygraphy. So compared to DICE polygraphy, we at our center, we have innovated and we have come up with this technique where apart from this endoscopy, we also monitor the multiple patient parameters while we are doing this sleep endoscopy. Here you have the ECG with the pulse rate, you have the oxygen saturation, the yellow curve with the yellow number is the bispectral index. If you see 98, that means that the patient is awake, has not been sedated yet. And also you have the respiratory rate and you have the blood pressure here. And also we monitor the external video of the patient to monitor what exactly is happening in this area while the patient is sleeping. So this is a technical. Generally for drug-induced sleep endoscopy, there will be only this endoscopy video. So we have kind of improvised on it, and we have included these 2 pictures into the video so that it has become more accurate and more, the inter-user variability is abolished by this thing. And when you see this video, so this patient is asked to identify himself when we start the endoscope, and we do an awake endoscopy
Just
with
the nose or local anesthetic spray மட்டும் நான் கொடுப்பேன்.
So local anesthesia spray.
இல்ல கண்ணு இருக்குமா மூடாதீங்க, just breathe normal.
So then we do an awake scopy. So we are doing this awake scopy. The patient is still awake, as you can see. So we do a complete upper airway endoscopy while the patient is remaining awake. So this is at the nasal velopharynx level, that is behind the nasal septum. So all those white material are not discharges. That is the 10% xylocaine spray that we have applied. So, and that is at the level of velopharynx. Now we are going, we have administered the drugs. You can now see that the BIS value is now at 40. You can hear the patient snoring. This is at the velopharynx. You are able to see that there is collapse happening on the lateral orientation. This is the salpingopharyngeal fold, which is collapsing. Anteroposterior, it is normal. And gradually we go, and this is at the oropharynx level. So you are having a lateral collapse at the oropharynx level. And if you see the epiglottis for this patient, so you can see that the epiglottis of the patient is kind of floppy and is obstructing every time the patient is attempting to inspire.
Floppy epiglottis.
So you can see that the epiglottis is collapsing and choking the airway. So this is the typical epiglottis collapse that we have been talking, and this will not respond to PAP therapy. So this patient will definitely have to be managed surgically, and the surgical solution is a very simple solution where the structure that you see here is the median glossoepiglottic ligament. If you can coagulate it with the coagulation device, this problem of epiglottis collapse will be completely abolished. So, and when it comes to treatment of patients with nasal pathology, all these are all familiar treatments. All of you must be aware: septal correction, inferior abdominoplasty, conchoplasty, complete ethmoidectomy for sinonasal polyposis, adenoidectomy for patients with adenoid hypertrophy. These are all treatments that we are all aware. All of these things have roles to play. And when it comes to dynamic airway collapse, you have three types of things that we do. We do soft tissue surgery, we do skeletal framework surgery, and we do mandibular advancement devices for these patients. So we generally have a concept of what is called as a box and contents. Box is the skull, and the contents are the soft tissue which are present inside. If we find out that the box is all right, that's the proportion of the skull is all right, the only the soft tissue inside the airway is abnormal, and if it is found to be the reason for the airway collapse, we generally advise soft tissue surgery for those patients. And if we find out that the skeletal framework is at fault, we work along with maxillomandibular consultants to do skeletal framework surgery. And in select patients, we also offer this mandibular advancement devices. So then when it comes to, previously I was touching upon this UPPP and why we don't do these days. And nowadays the concept of palatal surgery has completely changed. Previously we used to think that less tissue is more desirable, but nowadays that is not the concept. We don't kind of chop off tissues these days. In fact, for most of our patients, we don't even remove the uvula these days. So the concept is you preserve the mucosa. If there is adipose tissue under the mucosa, we kind of ablate it using devices like ablation. And when it comes to the muscle, that is the most important treatment strategy nowadays. See, these muscles, I was speaking about the dilator muscles and constrictor muscles. So what the current principle of any palatal surgery nowadays is to kind of make use of this, the airway muscles. We kind of take advantage of this knowledge, and we kind of augment the dilator muscles, and kind of we restrict the activity of the constrictor muscles. So that is the concept of today's modern palatal surgery. And whenever you have lymphatic tissues like adenoids and tonsils and lingual tonsils, we kind of excise them because they cause volumetric narrowing of this upper airway. So that is the current concept of palatal surgeries. I was earlier speaking about barbed wire sutures. These are basically sutures which were invented for use in plastic surgeries like breast augmentation surgeries and tummy tuck operations. But nowadays we picked it from them. It is basically a knotless sutures. You don't have to tie knots. You just pull it, put the knot and pull it. It will get self-retaining sutures. So this has made a lot of palatal surgeries with the modern philosophy very easy thing. Previously it used to be very difficult and cumbersome to put each and every suture, then tie them, then go on to the next thing. With this thing, it has made this treatment under current philosophy a lot easier and simple for us. And this is the philosophy that I was talking to you. So we use, there are certain rigid structures in the palate, that is the pterygomandibular raphe. You have the pterygohamulus here, and you have the posterior nasal spine, you have the palatal aponeurosis. These are all rigid structures which don't collapse. And we have other structures like the posterior pillar muscles which are prone to collapse. So we kind of take these collapsible structures, and if you take this collapsible structure and somehow anchor to the non-collapsible structure, you have a more stable airway which is less prone to collapse. So that is the current concept that we follow these days. And when it comes to retrolingual airway collapse, that is the collapse happening behind the tongue, we generally identify whether it is the lymphoid tongue base or if the patient has lingual tonsil. If that is the case, we do either a robotic or a simple coblation tongue-based reduction will help the patient. And if we find out that there is no lymphoid hypertrophy, it is only a muscular tongue base which is collapsing, then there is two choices. We will find out if the patient has retronathia. If the patient has any craniofacial abnormalities, we advise maxillomandibular advancement. And if there is no craniofacial abnormalities associated, then the treatment of choice for those kind of tongue-based collapse will be what is called as a hypoglossal nerve implantation, where an electrode is implanted into the hypoglossal nerve, which will synchronize with the inspiratory effort. Whenever the patient inspires during sleep, it will give a signal to the hypoglossal nerve, which will kind of pull the tongue forward when the patient is sleeping. So that is the principle of hypoglossal nerve stimulation. It is a surgical solution, and it is advised for patients with tongue-based collapse without any craniofacial abnormality. So that is the management of retrolingual collapse. And these are all tools that have come nowadays. Robotic tongue-based, the tongue-based, a lot of areas in this upper airway are very difficult or impossible to access previously. With tools like robotic tongue-based surgery, we are able to access previously inaccessible areas safely, and we are able to, you can see, already you can see with all these retaining devices, you are already able to see the posterior part of tongue here. And with these robotic arms, it is easier and convenient to work in those inaccessible area in a safe and effective manner. And this is a video, this is not a robotic surgery. This is just an angled endoscope and coblation being used to reduce. This is lingual tonsil. This patient is having a hypertrophied lingual tonsil. We are using a coblation wand, which works by the principle of plasma energy. So the liquid that is being flown is normal saline. See, the principle of this coblation is this, the edge of the device, produces a radio frequency discharge. And when it comes into contact with the normal saline, it splits the normal saline into sodium and chloride. And that results in the formation of a plasma energy field around the tip of the wand, which results in the coagulation and removal of the device. So as you can see in this video, gradually we are able to remove the entire lymphoid tongue base and thereby opening the space in that airways. And now previously we were not able to see the epiglottis, and gradually as we are debulking the lingual tonsil, you are able to see the epiglottis coming into view. So thereby we are able to open up the airway of the patient. And when you come to the end of the procedure, you will see that that area is opened up widely. And so that is at the end of the procedure, you are able to see a patent airway that we are able to produce after the surgery. So that is an example of what we can do with devices such as these things. And then finally about this, the craniofacial abnormalities. If you can see this patient, he obviously have a retronathia and he is also having a hypoplastic maxilla. We do what is called as a 3D CT facial bone. And with that, with software simulation, which are superimposing this soft tissue photo on the CBCT images, we are able to identify the exact pattern of collapse. And this is the airway volume. As you can see, this is the 3D CT image of the patient. You can see this is the volume that the patient has, that between the tongue and the posterior part of airway, there is hardly any space. And when the patient goes, and if the muscles relax, there is no space available, he will go in for a complete airway collapse. And there is nothing which can help this patient, not CPAP, not soft tissue surgery. The only thing that can help this patient is a craniofacial surgery, that is maxillomandibular advancement. So the maxillomandibular surgeons are able to accurately, nowadays we talk about AI and preoperative planning. So we employ such kind of thing. The maxillomandibular surgeon exactly know where to give the cut and how much of advancement has to be done. And we also can give the patient a rough idea, like, because this is going to change the facial contour of the patient. So we are able to give them a rough idea like how they will look post surgery. So that is the image that you have for reference. And this is the result after the procedure. So you can the predicted image, and this is not lot different, and the patient's obstruction is completely relieved. So that is the beauty of this procedure. And finally, coming to pediatric obstructive sleep apnea, Jayaraman sir was telling this is a very simple condition because in adult sleep apnea is a very complex disorder. So many factors are involved. So it is a very difficult condition. You have to have a thorough understanding and you have to treat it properly. But when it comes to pediatric obstructive sleep apnea, it is a very simple condition simply because 90 to 95 percentage of the obstructive sleep apnea in pediatric age group is because of this very simple condition called as adenotonsillar hypertrophy. A simple adenotonsillectomy can give relief to most children. You don't have to a technical expert or all these fancy technologies. You don't need a very basic surgeon that all of your ENT surgeons can do. Can give relief to all these kids. So that is what we have to do. So see, but problem is, like I was in my second slide, I was mentioning about a gentleman, because of the ignorance or whatever, they kind of propagate all these myths and wrong opinion about all these things. Any child with chronic mouth breathing, I think the entire of my entire talk, if I want you to take back one opinion, one take home message, if you want me to give, I would say never ever ignore a child with mouth breathing because it is going to have huge consequences. A child with mouth breathing simply means that the child is not able to breathe properly. And if a growing child is not breathing properly, it's not going to sleep well. And if he is not sleeping well, the brain development is going to be obviously affected. And if a child chronically mouth breathes, it is a growing child. The skull kind of responds to how the child breathes. If the child is not breathing through the nose, the skull is going to grow in such a way that he is going to develop what we call as a adenoid facies. They will develop a lot in this direction because nature tries to facilitate mouth breathing. The child develops what we call as a high arched and narrow palate, which we now see that in lot of adult patients with these craniofacial abnormalities, all these patients have had adenotonsillar hypertrophy with chronic mouth breathing, which has resulted in a subsequent craniofacial abnormality. So if a child has grown into an adult with a high arched palate with craniofacial abnormality, it is not the fault of the parents, it is the fault of doctors who have been ignorant about this simple condition, have not treated it at the right time. So the most important message that I would like to impress is never ignore a child with chronic mouth breathing. Definitely has to be evaluated. And finally, before I close, I would like to give an example which has been a very satisfying experience for me in as a surgeon treating obstructive sleep apnea. This was a 40-year-old high-ranking forest official. He was the official in charge of Sabarimala Forest Range. You can imagine Sabarimala Forest Range is the most important region in the entire Kerala, and if severe daytime tiredness, he was in fact referred to me because he slept off in one of the ministerial meetings before the minister. So that was the complaint, and his higher officials wanted to see me, and we did a level 1 sleep study. We found out that he had very severe sleep apnea, and this is we have the patient's permission. No need to be worried about that. This is the patient before surgery. He had a slight retronathia. We did a drug-induced sleep endoscopy for this patient, and we found out that he had a typical craniofacial abnormality, and no soft tissue surgery could be helping this patient. Definitely, you can see that his craniofacial abnormality is the reason for his problem. So we did a 3D CT scan with reconstruction. We worked along with the maxillomandibular surgeons. They advised that maxillomandibular surgery would help this patient. Then we did, this is him after the procedure. So it has cosmetically also improved his appearance. Even during the recovery period, in the third day, with all those plates and all those things in his mouth, with all those swelling, he got up from his bed and came to me and shook my hands with a grateful look. And he said, "Doctor, I have slept very peacefully and I feel so fresh after a very long time." So this is POD2 with all those pain and swelling. The patient was able to appreciate the improvement in the quality of sleep that he was able to experience. See, that is the amount of relief that you can give to a patient if you properly select your patient. I'm not saying that surgery is going to benefit all of our patients here. Like I was telling, we live in an era where holistic management of obstructive sleep apnea is the order of the day. There is nothing like CPAP is better, surgery is better, or other XYZ treatment is better. We have to customize the treatment as per the patient's problem, and that is something that I want you all to understand. It is the customization that is very important. So it is not the complex things, but it's the simplest of things that bring about the greatest change. A very important thing that we keep in mind. So we have to stick to the basics. We have to understand the patient better. It is not about any particular treatment modality. It is in how we understand the patient and his problem and how we treat it appropriately. That is going to make a huge difference for all those 45 million Indians who are going to require our treatment. With that, thank you very much for the opportunity. I shall be happy to answer any queries that you may have.
Thank you, Saktis. Brilliant presentation. Wonderful take-home messages. So, you did the procedure called DICE polygraphy. It's a very, very important thing. And pediatric OSA, any mouth breathing child, don't neglect. We have to catch them young and treat them young. So prevent unnecessary morbidity and lifelong problem using the irreversible OSA later adulthood. So a lot of take-home messages. So surgical indication. We have to choose the patient meticulously. Which patient benefit from surgery and oral appliances and CPAP therapy. One size does not fit for all. You clearly mentioned about CPAP is not the treatment. There are multidisciplinary approaches, very, very important. Thank you for the wonderful presentation. Any questions? One or two we'll take. Otherwise, we'll move on to the next presentation.
For children, sir, I'm a pediatrician. For children, how long we can give, steroid nasal sprays before proceeding to surgery?
Madam, I think that nowadays pediatricians are very much aware about this condition, but I think the very basic thing is that we have to assess even before we prescribe intranasal corticosteroids for the patients, madam. So we nowadays have flexible upper airway endoscopies which are very thin. The endoscope that we use in our center is only 2.7 mm. So we can even do an upper airway endoscopy even for a 1-year-old kid with that. So we have to identify, we generally look out for the adenoid grading. See, the adenoid grading is like this, like if the adenoid is occupying 25% of the nasopharynx, it is called as grade 1. Grade 2 is 50% of the nasopharyngeal airway. Grade 3 is 75. Grade 4 is complete obstruction. So the intranasal corticosteroids only helps only up to the grade 2, that is 50% of airway obstruction. Beyond that, there is no role for this intranasal corticosteroid. So evaluation is most important even before you prescribe. If you have an ENT surgeon who can do this flexible airway scopy, you should advise it. Or if you don't have access, it is better to do a CT scan because X-ray does not give you this exact volumetric analysis. X-ray is very inaccurate. Don't do X-ray adenoids. It is not advised. You either ask the patient to undergo a flexible upper airway scopy or do a CT-PNS, assess the adenoid grade, and then treat the patient accordingly.
Thank you, sir. And one more doubt, sir, because my patient, she's in steroids for, the ENT surgeon has asked the patient to wait.
Madam, you can unmute mic.
So the ENT surgeon has advised the patient to wait up to 4 years to proceed with surgery, sir, adenoidectomy, so that the patient is on long-term steroids, sir, more than 2-3 years. The patient is on steroids. Is there anything that age cutoff is there, sir?
Another very important common myth among doctors, madam. This is a very age-old concept. Previously, people used to say that for adenoid and tonsil surgery, a child has to attain 5 years or 25 kilograms. That used to be a very old concept where people were worried about bleeding happening in very young kids. Nowadays, we have better tools and technologies everywhere. Even in conventional tonsillectomies, we don't have much bleeding. But in the technology that I showed you, the coblation, the bleeding is hardly few drops. We don't have any bleeding. the youngest patient that I have operated personally is 10-month-old. So there is no concept called as age and weight limit for adenotonsillar hypertrophy. Our concept these days is no child should suffer from this airway obstruction, not even for 1 day or 1 month. So you assess properly. If it is grade 2 or below, you treat it with intranasal corticosteroids. Review after 2-3 months. If the child is significantly improving, wait and follow. Or otherwise, if even if it is a grade 2 adenoid and after 3 months of steroid therapy, if it is not improving, revisit your diagnosis, go for surgery. So you don't allow the child to suffer from airway obstruction for a very long time. That is the current concept.
Thank you so much, sir.
Thank you,
Sir,
madam.
one more.
Please.
What form of CPAP, I mean, any home device for children, sir?
Jayaraman sir, I think you will be able to answer it.
Yeah, ma'am. The adenotransrectomy is a treatment by choice in children, 80%. 20% of children may require the PAP therapy level 1 study for the confirmation and all. In the case of syndromic children, they have a hormonal imbalance and obesity. These kind of patients, apart from the surgery, we have to give the PAP therapy, CPAP therapy. We have a pediatric friendly nasal interfaces and the automatic PAP therapies. So this is the treatment modalities in that 20% of a pediatric OSA syndromic children, ma'am. Yes, ma'am.
Thank you, sir. Thank you.
Thank you very much, Saktesh, for the beautiful, awesome presentation. Enjoyed, lot of take messages. So we move on to the next talk, insomnia overview by Dr. Ramya Sampath, ma'am. Ma'am is senior consultant psychiatrist from MGM Healthcare. Insomnia is a very, very, very common disorders. Over to Ramya, ma'am.
Am I audible, sir?
Audible, ma'am. Yes, ma'am. Welcome.
Thank you, sir. Good evening, one and all gathered here. And I thank Jayaraman sir and the team for giving me this opportunity. Without much ado, let us just try and understand insomnia and how we go about evaluating or treating it. So really, it was a wonderful talk by Dr. Satish sir. There are a lot of nice new things that I learned today. Thank you, sir. So my presentation would be like, I'm unable to, yeah. So the outline of my talk is like, I'm sure all of us understand now the importance of a healthy sleep and how common is insomnia, how do we diagnose insomnia, and how all can insomnia present, and what are the therapies. So we all know that in a 24-hour time frame, at least 8 hours is spent sleeping. So we understand 1/3 of our life we are sleeping actually. So we need to really understand the gravity of how impactful it can be on the positive and the negative connotation. So sleep deprivation is linked to a lot of psychiatric conditions like depression, anxiety, and all that. And right from common cold, indicating a compromised immune function, to metabolic diseases like heightened systemic hypertension, cardiovascular morbidity, diabetes, metabolic syndrome. It is very important for you to understand that sleep plays a very, very crucial role. So sleep deprivation is associated with a lot of memory impairment, reduction in cognitive ability, and mood lability. And the physiological roles for sleep is to replenish energy reserves and modulate metabolism and facilitate a better learning and memory. So how common is insomnia? Insomnia is as common as 10% of adult population suffer from insomnia. And all of us as adults would have experienced a transient sleepless night in the context of a recent stressor, or because of a workload, or because of a gadget overuse. So it is very common to experience a transient insomnia or a short-term insomnia. But what is more bothersome is insomnia is usually a chronic condition with a 40% persistence rate over a 5-year period. So is insomnia does it mean just a sleep impairment? When somebody says, I have not slept enough, do we write insomnia that way? It is not so. Insomnia is a clinical diagnosis where DSM-5, the Diagnostic and Statistical Manual for Psychiatric Disorders, defines insomnia this way. So it is either dissatisfaction with the sleep quantity or quality. It can happen at 3 levels. There can be an initiation insomnia where the person toss in the bed for a long time before getting sleep. or it can just be an interrupted sleep, a difficulty in maintaining sleep. I go to bed. The OSA pattern that sir was explaining typically presents as difficulty in maintenance. So they sleep very well for 3 hours, then they have this apnea happening, then they wake up in the middle of the night and it is difficult for them to fall asleep again. Or it can be early morning awakening where they wake up early in the morning and have difficulty in getting back to bed. So the sleep disturbance causes lot of distress and impairment in all areas of functioning, and it is happening at least close to 50%, at least for 3 nights in a week. And it is there this way for at least 3 months. And it should happen despite adequate opportunity for sleep. So we all know the opportunity for sleep is also very varied these days. We have heavy deadlines or workload or schedule, which actually facilitates a sleep deprived state. So a lot of people tend to binge eat on caffeine or stimulants to stay awake at night and finish their deadlines. So that is not the context where we typically diagnose insomnia. And insomnia is not better explained by any other sleep-wake disorder or any other physiological effect of a substance. For example, you take a highly caffeinated drink like Red Bull or something, then you become sleep deprived. We can't call it as insomnia. So how do we understand insomnia? So insomnia starts...
6 o'clock ஆயிடுச்சு ஸ்விம்மிங் போலாமா?
So can you mute the other persons? I think there is some interruption. How do we understand insomnia? So insomnia, we have to understand in a longitudinal framework. So right from genetics, people can either be short sleepers or long genetic sleepers, or there can be lot of individual variations on what is their sleep requirement. And it is also moderated by sex, age, comorbid medical conditions, the medications that somebody is taking. For example, as we tend to age, the sleep tends to become more fragmented and more superficial. So insomnia naturally tends to become more common in elderly population. There can be a lot of precipitating events like recent stressors or a recent trauma or a chronic pain condition, which is aggravating the insomnia. So basically, there is an abnormality in the wakeful and sleep promoting areas of the brain and the internal clock or the circadian rhythm mediated by the pineal gland. There is a disturbance. So what happens as an end result of all these factors is the body goes into a hyperarousal mode. So there is a constant physiological activation of the hypothalamo-pituitary adrenal axis that our body is subject to. So what that results in insomnia or sleep deprivation. So insomnia can happen at multiple levels. If there is one thing that I would want you to really pay notice, there is a sleep switch model that is by orexin. Orexin is a neurotransmitter in the hypothalamus. We all know the sleep-wake centers is present in the hypothalamus. So what does orexin do? So what orexin does is it promotes wakefulness. So the orexin receptors in the hypothalamus promotes wakefulness. So, and it inhibits sleep. So generally people with insomnia have a heightened or a hyper-orexinergic tone. Apart from that, we also know there are a lot of neurotransmitters like sleep suppressing, like catecholamines, adrenaline, histamine, orexin, all these things are sleep suppressing neurotransmitters. GABA drugs or serotonin, melatonin, prostaglandins, all these things are sleep promoting. So there can be a lot of risk factors for insomnia. As I already mentioned, there can be medical reasons, right from structural and functional obstruction or OSA. It can be as simple as an acid reflux or endocrine problems like hyperthyroidism. It can comorbid happen with a lot of neurological conditions like Parkinson's. Any condition that causes a lot of pain physiologically can also trigger insomnia. Apart from that, psychological reasons, anxiety, depression, or external event-related stress can also cause insomnia. It can also be linked with a lot of lifestyle causes like excessive gadget use at night, sedentary lifestyle, not having any exposure to sunlight, all these things. So insomnia essentially forms the center stone for a lot of psychiatric conditions ranging from depression, anxiety. A lot of times people tend to cope up using unhealthy substances like alcohol. So I consume alcohol to just facilitate my sleep. So many patients report that and it can also precipitate a bipolar mania. So there is a lot of insomnia is a very, very distressing condition. So when somebody is unable to sleep, that is when overthinking kicks in, and the person can become suicidal if they are already having depression. So insomnia is not a very light thing to handle. So the presentations of insomnia can happen not only on the psychiatric angle, it can happen on various other specialities. So there is a hypothalamo-pituitary adrenal hyperactivation that I already mentioned. There can be accelerated atherogenesis or inflammatory markers, and there is a lot of inflammatory markers in the system. So it can predispose, or it can precipitate a cardiovascular event. It can present as worsening of hypertension despite adequate medications, worsening of type 2 diabetes or inadequate control, or it can present as exacerbation of an allergic rhinitis or asthma or thyroid disorder. Can somebody mute the other person? So there can be a lot of the pathological underlying mechanisms are there is a conditioned hyperarousal and there is a lot of fragmented sleep. The intermediate mechanisms being increased sympathetic tone, increased inflammation, and the HPA axis becoming dysregulated. So as I already mentioned, it can cause accelerated atherogenesis, palpitation, heightened BP, neurocognitive deficits, and mental health conditions. So when a person presents with insomnia, what are the factors that we should be looking for? We should be looking for biological factors, psychological factors, and social factors. So what does biological factor mean? Biological factor means that we have to look at insomnia from a medical angle. So biologically, anemia or hyperthyroidism or even vitamin D deficiency. So common medical comorbidities can have insomnia as a component. There can be a lot of psychological factors, ongoing stressors, ongoing coping skills, things like that. There can be a lot of social factors also. So the environment, for example, somebody is sharing in a PG. So this person goes for sleep and the other person switches on the light and is making a lot of noise. So the social environment, the family dynamics, the routines of the person, all these things play a very, very crucial role. So generally we need to rule out hyperthyroidism, anemia, vitamin D deficiency. Sleep study can be helpful if you are looking at some possible causes of apnea and or you want to understand the quality of sleep. So what do you actually offer for these patients with insomnia? So sleep hygiene is the non-pharmacological thing that we explain to all patients. So I think there is some noise. Can somebody mute that? So sleep hygiene is something that we psychoeducate all our patients with insomnia. So sleep hygiene basically means we insist on lot of physical activity in sunlight, exposure to sunlight, because that will tune your circadian rhythm, and definitely avoid gadgets 2 hours before bedtime and create a healthy sleep environment without much of stimulation. Having a very fixed sleep and wake up time. It can't be like you are working in a shift or you are changing your sleep time and wake time every other day. Establishing a smooth bedtime routine. Definitely avoiding stimulants, heavy meals, caffeine post evening will be very, very helpful. So the medication-wise therapies, we are using benzodiazepines, or non-benzodiazepines are the more preferred ones because they are less addicting or they don't have any hangover or long-term side effects. So zolpidem in 5 to 10 milligram dose is commonly prescribed. Melatonin supplements are preferred in elderly population or in pediatric population. It does not have any addiction liability or abuse potential or any hangover. Melatonin especially helps in people with shift work or circadian rhythm disturbances. We can also opt for drugs with sedating properties like a low dose of antipsychotic medications like quetiapine or something like an antihistamine medication for just relieving a short-term insomnia. Cognitive behavior therapy is very, very important, where we try and explain the patient's sleep patterns, the faulty cognitive beliefs that they have centered around their sleep habits. So the sleep practice guideline for chronic insomnia actually says medicines as standalone are only weak in actually addressing insomnia, which makes CBT and psychoeducation and ruling out other medical comorbidities as very important. So just to highlight the orexin that I already spoke about. So when the orexin levels in the hypothalamus level is very high, then the insomnia is also very high. So the severity is directly proportional to the hyperorexinergic tone in the hypothalamus. So I think this we already spoke about the behavioral management, the sleep hygiene education, and cognitive behavior therapy, where we are kind of facilitating the dysfunctional sleep cognition. Pharmacologically, melatonin or atypical antipsychotics, benzodiazepine receptor agonists, drugs which have a potentiating action at GABA, a zolpidem group of drugs, all these things are helpful. So one new molecule that is there in this armamentarium of insomnia management is the drug called lamborexant, which is basically an orexin receptor antagonist. So when we can simply understand that increased orexinergic tone is what is causing wakefulness at inappropriate time, then when we are inhibiting the orexinergic tone by antagonizing the orexinergic receptors, what happens is the wakefulness gets inhibited. So what happens is in insomnia is the orexinergic tone is very high. So it inhibits the sleep center and promotes the wakefulness center. So we say the patient with insomnia feels like the night is like the day. So I feel very fresh at night. I don't even get a trace of feeling sleepy. So the molecule lamborexant, which is an orexinergic receptor antagonist, is very helpful to inhibit the orexinergic tone, and it decreases the wakefulness and indirectly helps in better sleep. So the basic advantage with targeting this orexinergic receptor is it is more localized at the level of hypothalamus, and it does not have any widespread action, unlike the GABA and other molecules, where there is a lot of increased risk of fall or addiction liability and all that. So there is no withdrawal also. So that is a good thing. So lamborexant, the molecule, when you treat for at least 3 to 4 months, after that it can be smoothly tapered without any withdrawal or rebound insomnia. So it is very safe on a lot of angles. Even if we are getting a patient who's already abusing benzodiazepine for years, we can add this orexinergic receptor antagonist lamborexant and taper off the benzodiazepine, because benzodiazepine long-term use carry the risk of memory impairment and addiction potential. So that way, when we are able to kind of cross-titrate benzodiazepine with orexin receptor antagonist, it is very helpful. So this molecule, lamborexant, is available at 2 strengths, 5 and 10 milligrams. So it will be 5 and 10 milligrams. For pediatric or for elderly population, we can opt for 5 milligrams. So this is a summary of the medical management for insomnia. So benzodiazepines are basically working on the GABAergic modulation, potentiating the GABAergic tone. So there is a risk of tolerance, dependence, and withdrawal symptoms. But what we have to understand is they are excellent molecules in treating comorbid anxiety and insomnia. And when they are having a short-term stressor and insomnia, which is very heavy, benzodiazepines are definitely helpful. But we have to really emphasize or psychoeducate on the risks of long-term benzodiazepine abuse and insist on a regular follow-up and attempt down titration after a few months when the person is actually able to cope up or is able to follow sleep hygiene and work on the sleep pattern. Zolpidem drugs are very helpful in mild to moderate insomnia. The tolerability, the tolerance profile, dependence profile is all much more safer. Lamborexant is the newer molecule which is more specific for the wakefulness center and is devoid of any tolerance or withdrawal side effects or any abuse liability. So to conclude my presentation, chronic insomnia is a very, very undiagnosed clinical condition, but we need to understand it is not only a psychological thing. 1/3 of our life is spent sleeping. So it is very important to have a good quality of sleep. So when somebody is not having a good quality of sleep, holistic assessment is very crucial. And we have moved on from the traditional sleeping pills to wakefulness inhibitors alongside other non-pharmacological therapy like sleep hygiene and CBT. Non-pharmacological measures are very, very important in sustaining the recovery, especially when we are tapering the molecules that we are using for insomnia. Thank you so much for the patient listening, and I thank Jayaraman sir and the team for giving me this opportunity.
Thank you very much, Dr. Ramya ma'am. Wonderful presentation about the overview on insomnia. This is a common sleep disorders in practice. So majority of them we are seeing, they are asking the over-the-counter sleeping pills for insomnia, sleep apnea and all. So you said very clearly the sleeping pills role is only for the primary insomnia, that too after the sleep hygiene and cognitive behavior therapy, not the first line of treatment, but we have to choose the patient very selectively for drug therapy and all. So thank you very much for the wonderful presentation,
Thank
madam.
you, sir.
Any questions you can ask Ramya ma'am. Madam has to leave to other meeting shortly. So please to ask 1 or 2 questions. Thank you.
What is the dose of melatonin you advise, ma'am?
Melatonin for a pediatric population or for very elderly, we can start at 3 milligrams, madam. But generally, for a moderate weighing adult, you can go up to 5 to 10 milligrams. So usually they respond only dose close to 10 milligram if you are looking at monotherapy. If you combine with non-benzodiazepine like zolpidem, even 3 milligram would work adequately enough.
Is it in spray form, melatonin?
Pardon, madam?
Melatonin, is it a spray form or any other form?
Melatonin is available as tablets, as syrups. It is also available as nasal sprays. It is also available as gummies, something that the child, especially for pediatric population, as flavored gummies, you can chew the melatonin and the onset of action is also very quick. It is available in a lot of other formulations apart from tablets.
Can you please share your number, ma'am? Can you please
Sure, madam. I think I'll ask sir to update you. Yeah.
Any question or your advice for adolescents, ma'am? This for sleep related issues. What questionnaire you are using?
There is insomnia sleep survey. One general questionnaire is there, madam. But it is more, it is more helpful not to instead of administering questionnaires, we need to explore on the biological, psychological, and social angles. So that questionnaire is only just like a screening, madam.
Okay. Thank you.
Thank you.
If there are no questions, thank you very much.
Thank you, sir.
Thank you, Ramya ma'am, for the wonderful crisp and clarity presentation. If there are no questions, so we'll move on to the next presentation. Thank you, Ramya ma'am.
Thank you, sir.
May I call upon, I introduce Dr. Srivardhan. Welcome, Dr. Srivardhan. Srivardhan is a senior consultant neurologist working in the MGM Healthcare. He is from JIPMER, MD, DM, all, and he is one of the important faculty of our Sleepmed IMA fellowship course in sleep medicine. Over to Dr. Srivardhan for the talk on parasomnias. Over to Srivardhan, sir.
Thank you, sir. Is my screen visible?
Yeah, visible, audible, sir. Nice of you, sir.
Okay. Good evening, everyone. I thank Dr. Jayaraman, sir, and the IMA team for the opportunity provided. I know that everyone has been having a long day and the session started at 4 o'clock. And we just had a session about insomnia. And I'm pretty sure I don't want to put others into sleep by giving an extensive lecture. So I'm just going to give a very simple overview about parasomnias. So we just had a chat about insomnia. This is going to be about parasomnia. Historically and even mythologically, sleep has been something which has had a lot of attention. And when it comes to Greek mythology, sleep and death were believed to be siblings. The god of sleep was someone called as Morpheus, and the god of death was someone called Thanatos, and they were believed to be siblings. And it was believed to be an continuum, an extension. That is why when the words morphin, thanatology, they are all coming from those root words. Coming to the neurobiology of sleep, I'm not going to go into the chemicals and into the neurons which are concerned here. Madam just gave a detailed talk about the various drugs which we use. Benzodiazepines, the benzodiazepine receptor agonist, then the newer medicines in the form of dual orexin receptor antagonists and things like that. To make it very simple, there are 3 pathways inside the brain. The first pathway is the arousal pathway, which is starting from the tuberomammillary region. And the main neurotransmitter which is concerned with this arousal pathway is the orexin, followed by acetylcholine and histamine. That is why any medicine which is going to block the orexin, like DORAs, anticholinergics, and antihistaminergic agents, can lead to drowsiness and sleep. The second is the non-REM sleep pathway. The non-REM sleep pathway is primarily again located in the hypothalamus in the preoptic area. and it modulates a lot of other centers which is located in the floor of the third and the fourth ventricle in the dorsal part of the midbrain and pons. And the final pathway is the REM pathway. Why the REM pathway is different is because unlike the non-REM pathway which suppresses the brain, the REM pathway will aggressively stimulate the brain. At the same time, the REM pathway will inhibit the spinal cord, the alpha motor neurons of the spinal cord, which leads to the loss of muscle tone which we see in REM pathway. So your arousal pathway where the brain is fully activated, the non-REM pathway where the brain is very dull and it is calm, and the REM pathway where the brain is activated but the motor neurons are completely suppressed. And this is how the switch between the non-REM, the REM, and arousal pathway happens. Dream right now can happen both in the REM and non-REM state, and it is believed to play a key part in consolidation of memory. So this is how the various neurons located in the brain are concerned with coordination of sleep and for consolidation of memory in the form of dreams. With this very little knowledge, we will go into the concept of parasomnias. So this is how a normal sleep cycle actually happens. At the onset of sleep, we go into the non-REM sleep. We go from stage 1, stage 2, stage 3, stage 4. And then we have a REM sleep. Again, non-REM sleep, REM sleep. There can be a few sleep-wake transitions in between. And finally, you have the REM sleep and you wake up. If you notice, the initial REM sleeps are very, very narrow. But towards the later part of the sleep, the REM sleep becomes wider. In the initial stages, the transition across the different stages of non-REM sleep happens quite commonly. But towards the end, the non-REM sleep mostly lies in stages 1 and 2 and doesn't go to the deeper stages. Disruptions to sleep cycle, either during the continuous sleep or upon the transition to wakefulness, are categorized under the nosology of parasomnia. So parasomnias are a group of sleep disorders that are characterized by abnormal, unpleasant motor, verbal, or behavioral events that occur during sleep or sleep-wake transitions. The word parasomnias was coined by a French researcher, Henri Roger, in 1932. Non-REM sleep disorders are more common in the younger population, whereas REM sleep disorders are more common in older patients. REM sleep behavior disorder is seen only in 1% of the general population, but at least 50% of those with REM sleep disorder suffer from other common comorbid neurodegenerative disorders, especially Parkinson's. I'll again come to that a little later. So there are certain general rules when it comes to approaching a parasomnia. Non-REM parasomnias are seen in the initial stages of sleep because the REM sleep is much lower in the initial stages, while REM parasomnias are appreciated in the later stages of sleep a little well. Parasomnias tend to not occur more than once per sleep day. Say for someone is having a sleepwalking, they have only one episode that night. They don't have multiple sleepwalking episodes the same day. This helps us in differentiating parasomnias, especially the non-REM parasomnias from seizure. Non-REM parasomnias are complex and they act as if they are imitating a learned behavior or action. So sleepwalking, the patient will be walking, they'll be opening and closing. Sleep-related eating disorder, SRED, the patient will be getting up, they'll go out of the bed, they'll find something to eat, they'll open the package and they'll be eating it well. REM parasomnias, on the other hand, are very stereotypical. That's a violent behavior, a jerking movement. It doesn't involve a complex task like what is seen in non-REM parasomnia. Non-REM parasomnias are associated with event amnesia. The patient will not remember that they were doing all these activities. On the other hand, with REM parasomnias, there is a very vivid memory. The patient remembers it very well. So overall, if you are classifying the parasomnias, we have the non-REM parasomnias, which are called as disorders of arousal, which includes confusional arousal, sleepwalking, and sleep terrors. And sexomnia is a variant of confusional arousal. Then you have other non-REM parasomnias like sleep-related eating disorders. Then you have the REM parasomnia. It can be due to loss of REM metonia. As I told you, during REM sleep, the brain is very active, but the muscle tone is completely lost. If the patient does not lose the muscle tone during the REM sleep, we call it as REM sleep behavior disorder. The opposite can also happen where the patient will be transitioning from REM sleep to awake state, but the muscle tone loss is not recovering. This is called as excessive REM atonia. This can be seen with isolated sleep paralysis. So the patient in this particular scenario is in the sleep. The patient wakes up, but realizes that the patient is not able to move the body. Then you have nightmare, which is another REM parasomnia. Then you have parasomnia overlap syndrome, where you can have multiple parasomnias, or you can have a parasomnia with other sleep disease like obstructive sleep apnea, restless leg syndrome, periodic limb movements of sleep, etc. Then you have other parasomnias which cannot be classified as either proper non-REM or REM parasomnia. This includes exploding head syndrome, catatonia, sleep enuresis, and sleep-related hallucinations. Coming to the non-REM parasomnia. The most common non-REM parasomnia are the disorders of arousal, where there is absent or inappropriate responsiveness after the patient wakes up. There is limited or no cognition or dream reporting, and it is associated with partial or complete amnesia for the episode. So this is the ICSD-3 criteria for non-REM parasomnias. Recurrent episodes of incomplete arousal from sleep, usually occurring during the first third of the major sleep period. The individual may appear confused or disoriented for several minutes after the episode. Inappropriate or absent responsiveness, limited or no associated dream imagery, partial or complete amnesia for the episode. The episode is not better explained by another sleep disorder, mental disorder, medical disorder, or substance or medication use. The predisposing factors. So, for all this NREM parasomnias, there is something called as a 3P model. There is a predisposing factor, there is a priming factor, and there is a precipitating factor. So one of the predisposing factors is a genetic predisposition. Some people believe certain HLA phenotypes like HLA-DQB1 increases the risk of developing these parasomnia. Coming to the priming factors, in the previous presentation, Madam was talking about something called hyperarousal. So several things which happens during the daytime which prevents the patient from falling sleep properly, or which prevents or which leads to fragmentation of sleep gets built up. And finally, you have a precipitating factor. A precipitating factor is like the final tipping point. So right now we are having a war happening in Iran between US, Israel and Iran. It is not something which has happened overnight. There has been a tension which was building over several years, and a final event is tipping it. So similarly, there are certain final events which are going to precipitate. The most common precipitating factors are sleep deprivation, certain medications, and psychological stressors. As mentioned earlier, non-REM parasomnias are very commonly seen in the children, and they are commonly seen in the initial stages of sleep. Confusional arousal is seen in 17% in childhood, while in adults it is only seen in 7%. It is also called as sleep drunkenness, Eplenos syndrome, or morning sleep inertia. It is a disoriented behavior following an arousal from sleep. The most common parasomnia, which is captured during your polysomnography. I'll show you a PSG or an EEG reading a little later. These episodes often last less than a minute, but can be prolonged, particularly in the setting of sedative or hypnotic medications. Confused behavior is generally confined to the bed, For example, sitting up or pulling at bedclothes without sleepwalking or prominent fear associated sleep terrors. So in confusional arousal, the patient wakes up, but they're not able to respond appropriately. They'll be restricted to the bed, but they will be making some random movements. They do not get out of the bed, nor there is any evidence to suggest a autonomic system activation. Sexomnia is a subtype of confusional arousal. These patients invariably have a disorder of arousal in childhood. They can be triggered by something as simple as a bed partner's movement. The behavior can range from something like a masturbatory activity to even an attempted intercourse during sleep without awareness of the event, which can lead to a lot of potential familial and social issues. Sleepwalking, this is something which we have very commonly seen in movies or cartoons. It's also called a somnambulism. It's estimated that it contributes to around 14.5% of all parasomnias in childhood. Typically happens during stages 2 and 3 of the non-REM sleep. They experience repeated episodes of walking, often purposeless, after falling asleep. The patients end up getting out of the bed. They can roam. When they encounter a door, the task like opening the door, opening the latch will be well preserved. You can see that their eyes are wide open, but when you try to interact with them during the event, they do not interact. When you try to finally wake them out, they are confused for a few minutes and then they orient themselves back, but their recall is minimal. Waking the patient during an event can rarely lead to an inappropriate or violent response. So it is generally preferable to guide the patient back to the bed rather than trying to wake them up. Sleep terror. It's very common. In fact, most of us would have seen this in children. They'll be sleeping very well. In the middle of the sleep, they'll be waking up, they'll be crying for reasons unknown. They'll even be sweating sometime. All you have to do is convince them, you pat them, you cuddle them. After a few minutes, they settle. It's also called as night terrors or pavor nocturnus. It occurs in the first third of the sleep cycle. There is an abrupt partial arousal from delta wave sleep cycle, characterized by intense fears, sometimes accompanied by loud and piercing scream, and a sympathetic nervous system response in the form of tachycardia, tachypnea, flushing, and mydriasis. Adults sometimes jump out of the bed in response to a perceived threatening image or dream visualization, and sleep terrors are associated with frantic motor activity and screaming. The last thing in the non-REM sleep parasomnia is the sleep-related eating disorder, which does not fall under the disorders of arousal spectrum. It is very rare, contributing to less than 2% of the non-REM parasomnia. It is characterized by episodes of eating after arousal from sleep with limited awareness, but often a sense of involuntary or compulsive eating prevails. This is something different from night eating syndrome, which is a psychiatric illness where the patient eats more than 50% of their daily caloric intake at night, which is not a good thing to have. Patients with SRED often eat atypical food like uncooked food, or they might even end up eating non-food materials like rubber bands or sometimes plastic toys and things like that. We have even encountered patients who have ended up eating Lego sets in the middle of their sleep. And a strong association between sleep-related eating disorder and restless leg syndrome is documented. Then you have the parasomnia overlap syndromes. They can overlap with other disorders like narcolepsy, rhombencephalitis, multiple sclerosis, brain tumors, spinocerebellar ataxia, substance abuse, alcohol withdrawal. One particular disease which as neurologists we are commonly encountering now is the anti-Iglonfi disease, which leads to a combination of sleep dysfunction, parasomnia, and Parkinsonism. And historically, prion diseases, especially fatal familial insomnia, was associated with a variety of parasomnias. Coming to REM parasomnia finally. So before going to REM parasomnia, we'll see a little about the REM sleep. It was first identified or discovered in 1953 in the University of Chicago. REM sleep is marked by intense cholinergic activity from the basal forebrain and pontine nuclei, which activates the cortical activity. As I told you, cholinergic system is going to stimulate the brain. Cholinergic system is the dominant system for arousal and also the REM system. REM sleep related synaptic potentiation of memories works in tandem with and complements the synaptic depotentiation of non-REM sleep. REM arousal is associated with tachycardia, tachypnea, along with anger, paranoia, embarrassment, or sadness. This was the previous pathway which I told you for the REM sleep behavior disorder. So what happens is any lesion in the pons which happens or disconnects the ventral periaqueductal gray from the medulla and spinal cord can lead to REM sleep behavior disorder. So one of the experimental models for this something called as the oniric behavior of Jouvet's cat, which was an experimental model wherein these cats whose brain was transected were still roaming around doing complex movements which appeared like they were trying to do something meaningful. So what happens in REM sleep behavior disorder? There is loss of muscle atonia. These REM sleep behavior disorder characteristically present with repeated episodes of vocalization. We would have even commonly seen this in older people who end up talking, shouting, or even crying during sleep. It's called as dream enactment behavior. The behavior during REM sleep can range from mild activity like jerking, singing, laughing, shouting, to violent activity like eating or kicking, running in the bed, or falling out of the bed. They are more stereotypical and less complex. Like, say, for example, you take sleepwalking, where the patient gets out of the bed and they do a lot of complex movements. In REM sleep behavior disorder, it is more stereotypical. The behavior is often discomforting not only for the patient but also for the bed partner. They might even end up injuring the bed partner. REM sleep behavior disorder in younger patients is less male dominant. While in older patients, it is male dominant and is associated with certain neurodegenerative disorders like what I'm going to mention. So this is the ICSD-3 criteria for REM sleep behavior disorder. Repeated episodes of sleep vocalizations or complex motor behavior. Behaviors are documented by polysomnography to occur during REM sleep. Presence of REM sleep without atonia and polysomnography. Absence of epileptiform activity during REM sleep. And the sleep disturbance is not better explained by another disorder. So the REM sleep behavior disorder is primarily classified as either primary or secondary. Primary REM sleep behavior disorder can evolve into Parkinson's disease or multiple system atrophy at a later point of time. And several studies have shown that synucleinopathies are seen in 93% of REM sleep behavior disorder, and the conversion rate is 6.3 per year to 73.5 at the end of 12 years. Secondary REM sleep behavior disorder is seen in narcolepsy, autoimmune limbic encephalitis, brainstem lesions like tumors and demyelinations or pontine stroke, pontine hemorrhage, alcohol, and drugs. There are two specific drugs which are bigger culprits, which Madam was talking previously, to promote sleep. One is the zolpidem. The second is the newer dual orexin receptor antagonists like lemborexant or suvorexant. REM sleep behavior disorder can also overlap with other parasomnias, and interestingly, REM sleep behavior disorder was found to have a protective effect on comorbid obstructive sleep apnea. Because what happens in obstructive sleep apnea, there is loss of muscle tone. When there is REM sleep behavior disorder, this loss of muscle tone does not happen, or it will blunt the upper airway collapsibility. So the major causes of REM sleep behavior disorder are alpha-synuclein neurodegeneration, that is Parkinson's, then non-synucleinopathies like spinocerebellar atrophy, narcolepsy, structural lesions in the pons, and medication, SSRI, SNRI, DORA, the Z group of drugs, especially zolpidem. The predictors of short-term to mid-term phenoconversion to neurodegenerative diseases, that is less than 5 years conversion, in patients with REM sleep behavior disorder include presence of hyposmia or smell dysfunction, constipation, orthostasis, tremor, impaired color vision, absence of any serotonergic drug intake. The next disease is recurrent isolated sleep paralysis. It is the inability to perform voluntary movements at sleep onset or on waking from sleep. So as I mentioned, we have the REM sleep. Before waking up, the REM sleep goes into awake state. During REM sleep, there is muscle tone loss or muscle atonia. Once the patient goes to an awake state, this loss of muscle tone should be reversed. But what happens? There is no loss of muscle tone. So the patient is awake but feels like they are not able to move their limbs or speak or make any voluntary movements. Basic functions like breathing are unaffected. The events typically last seconds to minutes and can be aborted by stimulation such as being touched or the patient making an intense effort to move. But during these few seconds to few minutes, there is excessive fear or anxiety. Some people even believe that they are getting possessed during these events because there will be a lot of auditory, visual, and tactile hallucinations. Finally, nightmare. Nightmare is repeated occurrences of hellish thoughts that cause significant discomfort, which is not attributable to another mental disorder or substance or alcohol use. It's a distressing pattern of repeated dysphoric and vivid dreams. It consists of threats to survival, physical well-being, and security. Nightmares occur during the second half of sleep cycle with recollection intact upon wakening. They'll be able to remember what happened in the dream. Nightmares can be idiopathic or related to post-traumatic stress disorder, wherein some stressor gets lodged in their brain, and during the REM sleep, they keep reliving the stressful moment again and again, and that's why nightmares and PTSD commonly coexist. It's a result of hyperarousal accumulated during the day and maintained at night, as seen in PTSD and insomnia, combined with impaired fear extinction, where fear memories are continually reinforced. Nightmare script, seen as a maladaptive response to traumatic experiences, childhood adversity, organic sleep fragmentation as seen in periodic limb movements of sleep and OSA, and other cognitive and psychiatric conditions such as anxiety disorder. Coming to the other parasomnias which cannot be classified as REM or non-REM parasomnia, we have the exploding head syndrome, which is a benign disorder characterized by a sudden loud noise or exploding crashing sound in the head that happens during wake-sleep transition. It may terrify the individual, but it doesn't cause much of a headache. It was found that topiramate, nifedipine, and clomipramine are very useful in treatment of exploding head syndrome. Catatonia is something which we call as sleep-related groaning. So there will be recurrent episodes of groaning during sleep, which is different from snoring. It occurs during the expiration phase. It would be as if the patient is breathing against a closed vocal cord. This is a very, very close differential for obstructive sleep apnea. And it was found that CPAP is equally effective for management of catatonia. And we'll not be surprised to see that the same patient might have both OSA and catatonia at the same time. The last entity is status dissociatus. So it's a complete dissociation between the transition from wakefulness to non-REM and REM sleep, where there's a violent behavior like screaming, crying, crushing, kicking, punching, etc. It happens in the setting of a severe underlying psychiatric disorder, which leads to GABA thalamolimbic dysfunction, which results in complete disruption of your sleep architecture. What are the differentials for parasomnias? There are three major differentials which we need to keep in mind. One is the seizures, especially seizures which happen at night, like sleep-related hypermotor epilepsy, which was previously called as autosomal dominant nocturnal frontal lobe epilepsy. Conversion disorder can mimic parasomnias, and malingering. And malingering has a more legal context, which I'll be mentioning towards the last slide. So your disorders of arousal, sleep-related hypermotor epilepsy, idiopathic REM sleep behavior disorder, and nightmares. Non-REM parasomnias are common in the younger ages, while REM sleep behavior disorder are common after 50 years. With age, these disorders of arousal tend to disappear and they usually improve, while hypermotor epilepsy and REM sleep behavior disorder worsen with age. Non-REM parasomnias, it's usually only one episode, while others can have multiple episodes. Non-REM parasomnias are seen in the first third of sleep, REM parasomnias in the last third, and epilepsy at any time. The duration can vary, but non-REM parasomnias can go as high as 30 minutes. Awareness is usually absent in the non-REM parasomnia. In seizures, it is variable. And in idiopathic RBDs and nightmares, it is usually present. So coming to the adult lifetime prevalences, sleepwalking, confusion, arousal, and sleep terror are seen in around 22, 18, and 10%, while REM sleep behavior disorder is seen in 15%, and nightmare is very common, around 66%. How do we evaluate? Parasomnia is primarily a clinical diagnosis. A good sleep history outline needs to be obtained. Take a list of the prescribed and recreational drug use, especially SSRI, tricyclic antidepressants, SNRIs like venlafaxine and desvenlafaxine, monoamine oxidase inhibitors used in the management of Parkinson's, beta blockers, zolpidem, zopiclone. Benzodiazepine receptor agonists are likely to cause parasomnia, unlike pure benzodiazepines. The gold standard for sleep medicine is the polysomnography, but we don't commonly use video polysomnography for all parasomnias. They are helpful, particularly in atypical cases where injuries or violent cases happen, or to differentiate REM sleep behavior disorder from sleep-related hypermotor epilepsy. There are certain patterns like cyclic alternating pattern, hypersynchronous delta wave activity, which can be used as a marker to identify non-REM parasomnia. For REM parasomnia, video PSG is used in the diagnosis of REM sleep behavior disorder with a history of abnormal behavior during the presumed REM sleep and to demonstrate the loss of REM atonia. Coming to the treatment part, safety measures are very important. It should be adequately discussed with for both the non-REM parasomnia and REM sleep behavior disorder. Removing potentially dangerous items from the surrounding bedroom area is very important. Locking the windows, doors, or medicine cabinets in patients with sleep walking or sleep-related eating disorders is very important. They may not end up eating multiple tablets without their knowledge. Partners, family members should be explained about not waking the patient forcefully from the sleep. Potentially injurious parasomnias like REM sleep behavior disorder, you need to place cushions to avoid injuring the patient or the bed partner. Sleep hygiene and addressing hyperarousal needs to be done. Avoiding coffee, alcohol is very important. Treatment of underlying sleep disorders like OSA is very important. Multimodality treatment, including cognitive behavior therapy, needs to be done. And when it comes to medicine, the most commonly used tablet is clonazepam, which has a close to 86% success rate. Where clonazepam cannot be used, we can use agents like zopiclone and melatonin, which are relatively safer. For REM parasomnias, in addition to clonazepam, we can also use melatonin as recommended by the AASM. And because of the strong association with Parkinson's, we also use dopaminergic agonists. And because of the strong association with restless leg syndrome, we use alpha to delta ligands like pregabalin and gabapentin. So this is the list of medicines which were used in several studies. I'm going to just show one particular trial where 512 patients with non-REM parasomnias were used and sleep hygiene was useful only in 66%. Coming to the others, majority of them were treated with benzodiazepines. Some responded to CPAP. Some responded to the Z drugs like zolpidem and zopiclone. Some responded to melatonin. Then we used antidepressants like fluoxetine, cognitive behavior therapy, and miscellaneous. So it's a very varied group, with clonazepam being the most commonly used medication. What are the legal implications? This is something which I wanted to mention. So the diagnosis of sexsomnia, sleepwalking, or REM sleep behavior disorder can be used as a defense in high-profile cases of physical and sexual assault. The law clearly says that their patients are not legally culpable for behavior performed while they are asleep. Say someone has somnambulism and in the process of sleepwalking, they end up with an accident to someone else. The patient is not legally culpable, but they are legally culpable for the potentially negligent position they put themselves when falling asleep. Like, intentionally taking tablets, intentionally taking alcohol, or intentionally not maintaining a proper sleep hygiene in spite of knowing that they are having a parasomnia. So this is the legal implication. To summarize, during the sleep-wake transition, movements can happen, disorders of arousal can happen, while REM sleep behavior disorder, nightmare, and sleep paralysis happens in the REM sleep, which happens in the later stages of sleep. So I'll just show 4 or 5 EEGs or polysomnography readings. So this is how a confusion or arousal happens. You can see what happens during the non-REM stage 1 and stage 2 sleep, and suddenly the patient has a lot of violent, abnormal, vigorous movement, and the patient again goes back to sleep normally. You can see here. They go back to sleep as if nothing is happening. So this is how your typical REM sleep appears. You can see the movements in the electroculography without any movement in the EMG of the leg or chin EMG. Now, what happens here is you can see a lot of eye movement suggesting that it's a REM sleep with leg movements. This is what happens in REM sleep behavior disorder. That is loss of muscle atonia. This is something similar, but here you are having alternating right and left leg movement, which will suggest that the patient is probably having something similar to periodic limb movement of sleep. This is another patient wherein there is a lot of eye movement suggestive of REM sleep with EKG movement, arm movement suggesting that the patient is having a muscle movement during a REM sleep, which is suggestive of REM sleep behavior disorder. Same thing, electroculography and leg EMG, loss of REM myotonia. This was one of our patients with dementia with the Lewy body. This is your sleep triggered seizure. You can see a lot of abnormal activity happening in the frontocentral region, and it disappears into the background sleep of N2 stage. So a good polysomnography with the EEG can help us in differentiating between a non-REM parasomnia, REM parasomnia, as well as a seizure. With this, I complete my slide. Thank you.
Thank you, Dr. Sivardhan, for the wonderful, detailed presentation of parasomnias. So REM parasomnia, non-REM parasomnias, and lot of things. So history taking is a paramount important, and the over-the-counter medications and a lot of culprit behind the drug-induced problem and all. So wonderfully, enlighten all the details about the parasomnias. This topic is open for discussion. Any queries, please feel free to talk with. Unmute yourself and ask the question to Dr. Sivardhan.
Sir, parasomnia.
Yes, sir.
Pattern varies. Does parasomnia pattern varies according to the age and gender?
Definitely, sir. That's what we were saying.
Younger age. Treatment also varies.
Yes, sir. Younger age parasomnias, we generally don't want to treat. Mostly it's seen in children, college students, and the night நேரம் அவங்க ரொம்ப விளையாடுறாங்க, கஃபைன் எடுத்துக்கிறாங்க, ஸ்வீட் சாப்பிட்றாங்கன்னா அதை நம்ம அவாய்ட் பண்ணா போதும் சார். But older age parasomnia, especially if it's a REM sleep behavior disorder, we need to treat and we need to evaluate if the patient is having some structural brain lesion or if the patient is going to evolve into Parkinson's disease in the next few years. Younger age parasomnia treatment தேவையில்ல, older age better to treat, sir.
Deep brain stimulation, electrical therapy, ஏதாவது alternate இருக்கா?
Deep brain stimulation, right now we don't offer for parasomnias, but we
Okay.
use it for patient with Parkinson's disease with parasomnia. So
Okay.
the
Okay.
Parkinson's becomes an indication for deep brain stimulation, sir.
Okay. Well done, sir. Thank you.
Thank you, sir.
Common is the parasomnic manifestation in children, sir.
Sorry, ma'am. Sorry, can you ask your question again?
Commonest parasomnia presentations
Okay,
which you
the
see in
commonest
children.
parasomnia
Most of it.
presentation in children is sleep terrors, madam. The estimated prevalence is around 45 to 50. I think நம்ம வீட்டில் குழந்தைங்க இருக்கிற எல்லாருமே ஸ்லீப் டெரரை பார்த்துருப்போம். நல்லா குழந்தை தூங்கிட்டு இருக்கும், 1 வயசு 2 வயசு குழந்தை, just like that they will cry. எதுக்கு அழுகுறாங்கன்னு கூட தெரியாது. Again they will go off to sleep. So that is the commonest parasomnia which we see in children, madam.
To treat it, sir? I mean, are you advising medicine or?
No. There is absolutely no role for medicine. It's 100% self-limiting disease. Generally, for non-REM parasomnias, we don't advise medicine at all, madam. And if it's in children, definitely no. There might be very rare exceptions where we will be giving benzodiazepines or melatonin. These are the only two, and we always prefer melatonin over benzodiazepines.
The benzodiazepine can be given for a short time. How long is the maximum?
Yes, ma'am. Clonazepam is the preferred medicine. We use doses somewhere between 0.25 to 0.75 to 1 milligram in children. And for adults, we go up to 2 milligram.
Okay. I mean, how long is the maximum you can use? 15 days, 1 month.
Where
like
exactly we end up with a problem. Because Dr. Ramya, or not just Dr. Ramya, the current guideline for sleep and insomnia is to not use a benzodiazepine because it causes addiction potential.
Okay.
And we prefer using zolpidem or lemboraxant. But zolpidem and lemboraxant will increase the risk of parasomnia, where benzodiazepines are preferable. So in patients with REM sleep behavior disorder, we use benzodiazepine for several months. But for other disorders, we restrict it to 2 to 3 weeks and we don't give beyond 2 to 3 weeks.
Any form of CBT is advised with parasomnia.
Yes, ma'am. CBT is the first line medication. Yes, ma'am. CBT is the first line medication for management of parasomnia. And I was mentioning in the pathophysiology that hyperarousal is a key feature of any parasomnias. So a proper sleep hygiene, cognitive behavior therapy, we have so many aspects of CBT to address sleep hygiene. If you are just addressing the sleep hygiene properly, the parasomnias will improve by themselves.
Thank you, sir.
Thank you very much. If there are no questions, so to conclude, we had a wonderful talk by Dr. Sivardhan, neurologist perspective, the parasomnias. So we had a wonderful 5 lectures about the sleep and sleep disorders, pulmonology perspective, neurologist perspective, psychiatric perspective, and the surgical ENT perspective. So thank you very much all the faculties for the wonderful presentation for this World Sleep Day commemorative lecture. I thank the IMA AMS team for the wonderful opportunity to present in this August gathering of our IMA and non-IMA doctor. Those who not joined IMA and AMS, welcome to join this and join the course, Sleepmed IMA courses, those who are interested in the sleep and sleep disorders. So this year theme of World Sleep Day is sleep well, so live healthier. So sleep well, live better. This is the theme of this year. So sleep is a lot of issues, starting from insomnia, sleep apnea, parasomnia, narcolepsy, the lot of diseases. We have to have a meticulous history examination, and the gold standard test for sleep disorders is the PSG. So we have to evaluate properly. One size does not fit for all. We have to have the multidisciplinary approach. We have to involve the neurologists, psychiatrists, ENT surgeons, endocrinologists, bariatric surgeons, dentistry, and pulmonologists lead in sleep-related breathing disorder. Among all the sleep disorders, insomnia and sleep apnea is a very, very common, and meticulous history will clinch whether associated comorbid sleep disorders like parasomnia, narcolepsy we have to pinpoint. So I thank you all for the wonderful, beautiful presentation of all the faculties, all the delegates. Thank you. Over to our AMS team, Dr. Ibrahim, for the closing remarks. Over to Ibrahim, sir.
Thank you, sir. Thank you for the wonderful moderation and presentation on Sleep Day and inauguration of the Sleep Fellowship course. On behalf of the IMA TNSB AMS team, I thank our IMA TNSB office bearers, our president, Dr. Sridhar sir, and our secretary, Dr. Thiraviya Mohan sir, and Dr. Solomon Jaya for being present in the inauguration. And I also thank our immediate past president, Dr. P. Senguttuvan sir, our president-elect, Dr. A.K. Ravikumar sir, and Dr. N.R.T. Tyagarajan sir, and also members of the AMS national team, Dr. Venkatachalapati, Dr. Amudan sir, and Dr. Sairam sir for their present here. And on behalf of the IMA TNSB AMS team, I profoundly thank the participants, the delegates who are interestingly involved. And the strength was almost 700 plus throughout the meeting. And even at the end of the last symposium, last speakers talk, it was almost 500 plus. And over to the speakers, all the 5 speakers made a wonderful presentation, and in spite of such a big topic, there was no overlap in their presentations. And sleep medicine is going to be a new stream in the management of sleep related disorders, and I request the IMA AMS members to join this course, which will be definitely useful for their routine day-to-day practice. Once again, I thank on behalf of IMA AMS team, and I request the members to join IMA and also the AMS, and also keep themselves updated in the AMS WhatsApp group for the continuous updates on various CMEs conducted by AMS. Thank you, sir. Thank you all.
Thank you very much. Good night. Good night sleep. Thank you.
Providing this course and who are eligible, sir. Sir, what specialties are eligible to join this fellowship in sleep medicine course?
Sir, Jayaraman sir. Madam, are you in the AMS WhatsApp group, madam?
No, sir.
Can you just share your WhatsApp number in the chat box so that we'll send the details?
Okay, sir.
Madam, your name, madam?
Sir.
Yeah. Please share in the chat box, madam. We'll send you the details.
Yes, sir.